Ah, você viu bem, certo? Hum?
I didn't remember me.
Zica.
Hello, good evening. Our facilitator is here with us. Sorry for the delay. Sir, I think you can start.
All right. Good afternoon, everyone. Sorry, I'm really sorry for the delay. I just came back from work. Sorry about that. Let's get started. So I welcome everyone to today's edition as well on our Advanced Acute Physio Essential. And thank you for being here, everyone. Thank you, Dr. Idris, for the organization. And I also welcome our newest member. May God be with him as well. So let's get started. So today is going to be on positive pressure therapy. So we try as much as possible to cover everything positive pressure. And I really like to say that this is a very, very, really important things we all need to be familiar with as an acute physio. Even there could also be some patients that might be needing some ongoing support with some of these treatment adjuncts. They are really, really very, I'm saying to this now, they are really, really and very, very evidence-based. So we need to familiarize ourselves with it. Unfortunately, we might not be able to cover everything because it's really, really a very huge topic. And but I would do, and again, I would say something that also, yeah, like practical related, but I would do my bit to cover as much as I can do to build some clinical concepts, some basic understanding around all of these things. Hopefully in the end, we can have some confidence, and maybe in the future, we keep building on some concept that we have some concept we'll be able to lay today. All right, can you guys hear me, please? Hello, can you hear me? Hello, can anyone hear me so we can start? Or am I speaking to myself? Hello?
Yes, I can hear you.
Oh, okay, all right. Thank you very much. Just confirming. So before I dive into my own slide, I would like to hear our wealth of experience around positive pressure. What does it really mean to us? Because I am aware we all have different experiences when it comes to positive pressure therapy. To some people, it might even be the first time hearing this. To some people, it could be something they are familiar with, one or two treatment adjuncts relating to this. So what does it really mean to us as physio? If anyone can pop in some ideas in the chat box or just share some of their experience around this. What does it mean to us? Is there any of these treatment adjuncts that are currently available in our facility where we work? PT Vincent, are you able to mute yourself? Thank you. So is there any of these treatment adjuncts that are currently available where we work? And what is our role as physio when it comes to these? Anyone, just to understand, because I know we are coming from different backgrounds when it comes to positive pressure therapy. So I would just like to, first of all, hear some of our experiences so that we know where to tune our discussion. Anyone? I'm on the chat box. If you like to speak as well, you can open your mic. This is really, really very evidence-based. Yeah. Yeah, thank you. Okay. Yeah, thank you, Peter Ruben. Yeah, you mentioned that he's just hearing this for the first time. Thank you for that. Thank you for being honest. Yeah. Any other one? Any other person? Another person, positive pressure. What does it mean to us as physio? So while I leave you guys to pop in responses in the chat box, I will just crack on because of time. So let's get started. So first of all, when we say positive pressure and when we say negative pressure is just what you and I are currently doing at the moment. We are both breathing on our own. We are not on any breathing tube. We are not having any breathing tube. We are just doing our normal breathing, tidal breathing. We are taking in deep breath. You are breathing out CO2 as well. So how does that work? If you look at your respiratory mechanics, the diaphragm comes down, diaphragm descends, it gets flattened. What happens in the thorax? The thorax becomes bigger, air starts rushing in. That's just negative pressure breathing. This is normal breathing. But to some patients in the hospital, their breathing becomes problematic because of a lot of reasons. It could be because of the chest infection trying to kill them. It could be because of their neuromuscular conditions they've had. It could be because of trauma. It could even be because of it could even be in the community setting. Patient, please. I won't like to have this today. Please, Pitificent. So now, like I was saying, it could be now some patients, because of their ongoing medical conditions or ongoing neurological conditions or because of trauma or because of anything, they might be needing external support. They might be needing devices to support their breathing. It could be, we're going to talk about some of those devices. It could be devices that can offload their breathing, that can remove. Imagine patient that is currently, they are currently distressed. Their respiratory is just really very high. Their chest wall is just rising and falling quickly. They are very distressed in bed. They are fatigued in bed. We can pop some of these patients on some devices that can offload their breathing, that can support their breathing, that can even remove the effort of their breathing, that can remove the effort they are using to breathe, to ventilate, to make their work of breathing much more easier for them. These are some of these devices. It could even be, imagine a patient, maybe spinal cord patient, for instance, high spinal cord patient. We have talked about spinal cord in the past in one of our trainings. It could be high spinal cord patient, maybe they've got maybe injury above T6, something like that. They are struggling with cough. They cannot clear their airway independently. We need to support them. We might be supporting some of them with some of these devices, like positive pressure devices. We're not talking about that. How does it work? It's like I said initially, this is very evidence-based devices that we need to be familiar with. We need to be able to support patients with. We need to have good clinical reasonings on how to operate all of these things. So now, so like I mentioned, if I just come to this slide here, like I mentioned, normal breathing is just negative pressure. Normal breathing, spontaneous breathing, the one you and I are currently doing at the moment. The diaphragm is coming, is just descending. What happens? We have big space in the thorax. The air is filling in the lungs, and we are breathing out CO2. You know, if you remember secondary school, these Boyle's law kind of things, if you remember that, you know, if pressure and volume are inversely proportional, when you have big, what happens is when diaphragm descends, there will be a lot of space in the thorax. Don't forget the diaphragm separates the thorax from the abdomen. So when diaphragm descends, there will be a huge space in the thorax. So the pressure in the thorax is going to drop. So more air can then diffuse in from the atmosphere into the lungs, which makes sense. So that means for normal breathing, what you and I are currently doing at the moment, the pressure inside the chest is slightly lower than that of the atmosphere. That is why air can rush in from the atmosphere into the lungs. But unlike positive pressure, we might not really need that pressure we might not, unlike positive pressure, you just need a device to push in here into the lungs. And which means for the devices now, the pressure you are pushing in might be a bit greater than the pressure in the atmosphere. What do I really want us to remember here? Normal breathing, spontaneous breathing, negative pressure, positive pressure, you need external devices. And patient group, remember patient group that might be needing this. Some patient might be at the highest level of care in the hospital. Some people might be in the ITU, they might be in the ICU, some might be in the HDU, for instance. And some patient might be on neuro ward. They've got neuromuscular conditions, they've got spinal cord injury, they've got spinal cord injuries, it could even be on PET, for instance. You can have Duchenne muscular dystrophies, you can have spinal muscular atrophies, you can have some of these patients that are struggling to clear their airway. They might be needing positive pressure to support them. All right, it might be a trauma patient. It might be trauma patient that now the respiratory mechanics, the pump has been impacted, or it could even be on medical ward. patients that are fatigued because of ongoing medical needs they have, or it could even be patients struggling to sleep overnight, because of when they sleep, the tonic and respiratory muscle becomes lower than expected. They tend to retain secretions or something like that. It could be some patient like that. So these are some of these explanations that we need to understand first of all before we dive into this thing proper. All right, is it making sense to us? Are we trying to get some ideas of what this thing is all about? Can I get some response? Yeah, PT Gidado is asking, is this the same as soft tissue manipulation? The answer to that is a completely different things. It's just different things. Soft tissue manipulation is entirely different from this. Everything we'll be discussing here is just basically on respiratory support, how you can support patients that are struggling to ventilate, or they are struggling to clear their airway, or that might be needing to even go into ITU for to get intubated and sedated or being ventilated. I'm going to break it down. It's not really a big thing, but I'm going to make it practical and very simple, like I mentioned, and because this is really hands-on based kind of things, but we need those clinical reasoning first of all. We need those on that basic understanding. Even if we need to come down to do some practical, we still need theoretical knowledge, background, indication and contraindication, all those kind of things first of all, before we say, yeah, let's get hands on the machine on all of these things. And like I used to say, again, this is another things again that are not well taught in our undergraduate days. And again, these are just like how will I put it now? This is just like we are just sensitizing ourselves, getting our lecturers in our schools to include some of these things in the curriculum. These are evidence-based stuff. These are, like I used to say, there are a lot of things we teach that might not be obtainable in acute hospitals, especially for patients that are very, very sick. So we need to start thinking about how we need to include some of those things in the curriculum and start getting the necessary skills to be able to handle patients that are acutely unwell in the hospital. All right, so let's continue. So PT Girado is completely different thing. Okay, so and again, I also like to say this, if at any point I'm not making sense, or you've got any questions, or you've got any idea or opinions, just pop them in the chat box. I'll be checking that alongside as we continue in this slide. All right, so let's continue. So why is positive pressure matter? We have known what negative pressure means. Now we are fixing on positive pressure. Why does it matter? Of course, from previous explanation, we can relate. We need positive pressure to support. If somebody is struggling with secretion management, either because of neuromuscular conditions they've got, or either because their breathing center is being depressed, or either because they've traumatic injury, brain injury they've had, or either because chest infections that is trying to kill them has now overwhelmed them, or anything, or either because anything. It could be cerebral palsy patient with weak muscles of respiratory muscles. It could be it could be any conditions, struggling to clear airway. Some of these patients might be needing positive pressure. It could be patient with work of breathing. They are really, really very fatigued, struggling to ventilate. We can get some of them on some of this equipment on this device. It could be patients with retaining CO2. If you go back to the teachings, to the trainings we have done on ABGs, you can relate that some patients, they might be chronic retainers of CO2. There might be some patients that might be struggling acutely to deal with CO2, pumping up CO2. Some of them might be needing some of this equipment. And again, it could be maybe a patient, they have been in the hospital for a while, they have been very, very sick, very poorly, they've been admitted in the ITU. Now they've been having breathing tube for a long time. Maybe they've been intubated, for instance, they've had trachea or ET tube or something like that. So we now want to wean them off those mechanical ventilator. We can extubate some of these patients. We can remove them from the vents, remove the breathing tube or thereabout, and put them on some of these positive pressure devices to support their breathing. And on that positive pressure, we can continue our physio. Even while they are still on mechanical ventilator, we are still doing our stuff. Physio is very, very important for this patient. All right. So these are some of these patient group and some of these indications why patient might be needing positive pressure. All right. So let's look into our toolkit. What have we got? When we say positive pressure, what have we got? By chance, if you have been following these trainings right from those acute care discussions, you could have heard we talking about some of these things, by chance, speaking about some of these things. Of course, when I was also talking about spinal cord injuries, we also mentioned some of these things as well. You might have heard about high PPB kind of things, intermittent positive pressure. What does it mean? We're going to discuss just basic concepts, and I'm going to show you some pictures. Don't be terrified. Don't be anxious. I'm going to just keep it very, very simple so that we can build basic concepts. I am happy to come as many times to build advanced knowledge about all of these things, but let's keep it very, very simple today. All right. So we can have MHI, that's mechanical hyperinflation. What does it mean? What do they do? We're going to talk about it. You can have cough assist, MIE, some people call it MIE, mechanical insufflation, exsufflations. You can have NIV, it could be BiPAP, it could be CPAP. And some people, again, nomenclature kind of thing, some people might just call NIV. In their center, it could be NIV is what they call BiPAP. It depends. And again, you can also have patients going into full ceiling of care, level 3 care in the hospital, like going into ITU, being intubated, being plugged to mechanical ventilators. Of course, mechanical ventilator also operate on the concept of positive pressure. So these are our two key. These are what we, and again, I've not included that here. You can also have patients that have this passive positive pressure device like Flita, Acapella, PIP devices, and all of these things. Yeah, these are also respiratory adjuncts. Like I mentioned, all of these things are really, really evidence-based, and we need to familiarize ourselves with it. If you want to start seeing patients that have been acutely sick, or even patients that are not really sick, but they will be needing ongoing support from some of these devices, we need to start thinking about how we get full knowledge about all of these things. All right, so what is this first one? This is MHI. Of course, I think this is well available in our center, in our specialist center. Yeah, this can be used to recruit patient lung volume, to give them deep breaths. Don't forget, let me just start with a simple concept here. We are breathing now, we are breathing in, we are breathing out, right? This is tidal volume, normal volume, relaxed breathing, all right? So if I need to give a patient big breath, like big inspiratory breath, I can try some of these things. I'm going to still talk about indication, just breathing basic concepts now, all right? So now look at the second one. This is MIE, cough assist device. Yeah, there are different models, there are different makers. If you go online, you find different pictures, but this is MIE. The next one can be CPAP, it could be BiPAP, depending. You can find this IPPB. This picture here is just, yeah, something looking like mechanical ventilator kind of things, all right? And these are passive positive pressure, or these PEP devices that can be used for patient care as well. So when do we think about all of these things as what do they really mean? Let's move forward. Sorry guys, are we getting these things? Is it making sense? Are we there? Or is it looking boring? Hello? Hello? Or do we really think we don't have to teach, we don't have to train ourselves on all these things? What do we think? No? Hello, anyone there?
We are with you, sir.
Yeah. So do we really think we have to have training on these things, or it's not just important, or we don't really have patient group that need these things in Nigeria? Or what do we think? Or patients that really need these things, what have we been doing at the moment to compensate for not having some of these things? Yeah? Anyone? Or is there anything, because we really need these things, we need them. Yeah. Thank you. Anyone? What do we think? What are we doing at the moment? Like looking at our physio toolkit now, currently now in Nigeria, if we have a patient, they are suddenly very, very poorly, just imagine cough. Now let's look at cough, for instance, now. Yeah, because we know we're going to talk about cough, it's like very soon. Now we have patients being poorly, or being, let's say in the ITU, for instance, they are sedated, blah, 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 and we are limited in other treatment skills that we've got in our toolbox. So what are we doing currently for them? Because we need to be reflecting. That is how we can improve our practice. We need to be reflecting. If we are not reflecting, there won't be any change. Yeah. So what are we doing at the moment? Maybe moment of reflection. What are we doing at the moment for them? Let's reflect. That is why we are here. Okay. Who is helping us? Thank you, everyone. Yeah, I can see some comments in the chat box. Yeah, we really need them. Thank you. Yeah, it is okay, sir. Yeah, making sense. Thank you. Yeah. Anyone, what are we doing at the moment? It might not necessarily, patient might not necessarily need to be in ITU, for instance, or ICU, for instance. It might just be on neuro ward. They are poorly, they are 60% oxygen, not having good cough. What are we doing with them? Not having good cough or work of breathing, this thing. What are we doing? Now, or it could even be maybe some of them needing NIV. What do we see as physio to speak with the MDT that this patient will be needing to be escalated on another device or to offload them? Like, what are we checking? Like, what are we going to see in those patients to make those decisions to say, no, I can't do anything as physio. Yeah, this patient need to go on NIV, this patient need to go on CPAP, for instance. What are we going to see? How have we been making those decisions at the moment? That's what I'm asking. Yeah, PT Ruben, here we are restricted to using the modality, but we need them. Thank you, PT Ruben. Yeah, we need them. Yeah. So what are we doing? Anyone? It could be pediatric patient, beyond PM, standing training or everything. Yeah. Every patient can stand, of course. They might not be needing all of these things. But yeah, are we those neuromuscular patients that are coming to our facilities, Duchenne muscular dystrophy, spinal muscular dystrophy, those patients, are we really assessing their cough strength? Are we looking at those things as well? Are we doing those things? Beyond the strengthening, the stretching, and all of those things, we need to be checking those things. How about spinal cord injury patient, an injury above T6? We have had discussion about that. It's really, really important. We need to be doing some certain things. All right, let's move forward. Hopefully we can lay some concepts. So I will keep this slide for now, or maybe I just quickly run through it, and then I will come back to it again. Like I mentioned, when you hear cough assist, just like the name implies, cough assist, assisting cough, augmenting cough. Patients that have weak cough, patients that did not even have, like, their cough is absent, maybe because they are drowsy at the moment, maybe because they are in pain. If you are working on what is it now? Surgical work, for instance. Physical work, they've got laparotomy, they've got thoracotomy, they've had surgeries to their chest, abdominal surgeries, because of pain, because of anything, they've got weak cough. Or even it could be because maybe they are currently on any medication that is suppressing that breathing center. You might be thinking, where do I go from here? Retained secretions, you might be thinking, cough assist. Yeah, we're still going to talk about proper indications, and this is just like a basic concept kind of things. Increased work of breathing, yeah, maybe they might be needing that. Collapsed lungs, they might be needing IPPB, they might be needing cough assist, they might be needing any of them, any of these things. These things are not, these things are just clinical reasoning based. And think about why, if I will be, PT Ajara, please. If I will be escalating any of my patients on any of these devices, there should be a clear clinical reasoning. And again, I also need to think about it. What have I tried before thinking about some of these devices? It's just clinical. Everything we'll be doing is just basic concept and clinical reasoning discussion. Now, let's talk about contraindication first. And maybe later on, I can come back to do that previous slide. So contraindications. Anytime you hear positive pressure, either cough assist, either manual hyperinflations, either ventilator hyperinflations, either NIV, for instance, BiPAP, CPAP, any of those things, you have to think about it. Contraindications. Their contraindications are quite very, very similar. Think about pneumothorax, first of all. Pneumothorax is just here between the two pleural cavities, your visceral pleural and your parental pleural. So why are we concerned about pneumothorax? First of all, let's ask ourselves, why are we concerned about pneumothorax? Anyone? Can anyone? Because we're going to do this together. So can anyone help? You can pop something and some ideas in the chat box. Why are we so concerned about pneumothorax? Why are we concerned about pneumothorax? Don't forget, normal breathing, negative breathing. What I'm doing at the moment, what you are doing at the moment is negative breathing. But if somebody will be needing external devices to give them here, then it becomes positive breathing. Now, if I'm start giving them here, positive here, going into their lungs, the chances there, if there is a loophole somewhere, if there is a gap or there is a like a fistula or opening or anywhere that here can start leaking into, the chances also because the hair is not guided, it's just like I'm just pumping in here to their chest. The chance is there that those here can start leaking and going into here, like here leak into their pleural space. So if you've seen, let's say for instance, now you've got a patient in front of you, you want to treat, you have to be really concerned about pneumothorax, look into their chest X-ray, speak with the medical team. Is there any concern with pneumothorax? If there is concern with pneumothorax, then I need to ask myself. Because the chances there, if I give them positive pressure, the air might leak into their pleural space. And what is the implication to that? The implication to that is the air leaking in can compress their lungs. Don't forget, ideally, the visceral pleura and pleural interpleural, they are very close. They just slide and glide over each other. But now, if you now put here in between the two spaces, like more than expected, what does that mean? You can compress the lungs. And from there, you can also compress the heart. You can give, even if a patient is coming to the, or maybe currently now, suppose I've got a patient in front of me, they've got simple pneumothorax, and I can start giving them a lot of positive pressure, the chances there that they may end up getting tension pneumothorax. And tension pneumothorax is where you don't want to get to as a physio. This is medical emergency. Because that will compress their heart, that will compress their lungs, their cardiac output will start dropping or start having some cardiovascular instability. You don't want to get into that lane. Think about it. And again, if anyone asks me one simple question here, and the simple question is, in all of, you can have plenty, thousands and thousands of contraindications. What is that one big contraindication you need to be aware of? I would say pneumothorax. Do you know why I'm saying pneumothorax? I'm going to tell you. The reason is this. Suppose I've got a patient in front of me. Day one, I go to their bedside, I do my treatment, do everything. I give them positive pressure, blast them positive pressure. I'm clearing secretion, and they are fine. We are winning the oxygen. Day two, I go there, or it could even be any of my colleagues. Day three, you know, as we are giving them, like, before I commence them on that treatment regimen, on that positive pressure, their chest rate was completely fine. Everything is fine. Everything is okay. Now, alongside, it is also my responsibility because generally, as you progress with your treatment, the medical team, they're also doing their own bit, supporting patients with if they need steroids, if they need antibiotics, if they need diuretics or whatever things they need or whatever bronchodilator or what, they're also doing their own bit. You might be telling them, you might also like maybe tell some of them, yeah, request for chest X-ray. Let's keep monitoring what we are doing, looking at their chest, looking at secretion, looking at lung lobes. Let's visualize this thing. Let's see. Yeah, just to use that to complement whatever assessment I'm doing at their bedside as well. Yeah, you are not also only checking that chest X-ray for improvement. It is also your responsibility to be checking that chest X-ray for any contraindication that will make me to stop my treatment that I'm doing with that patient. Because I know that I am pumping here into their lungs, positive here into their lungs, that's supposed to be negative pressure, that nature has made the lungs to be doing normally. The chance is there that some here might find their way leaking into the pleural space. So if anyone asks me, what is this big one contraindication, I'm going to say it is your risk. Aside from, yeah, what I'm saying is day one, patient might be completely fine. And as you progress into your treatment regimen, you can also give patient pneumothorax. That is what I'm saying. But I'm not saying 100% when you use positive pressure, IPPB, patient must have pneumothorax. But it is your responsibility to ensure that you are tracking that, what you are, because at the same time, you are trying to help them. But you should also like assess your treatment and ensure you treat patient case by case. For instance, if I do day one, day two, day three, and I just look at the chest X-ray and say, yeah, this is looking like a pneumothorax, I might want to stop, or I might want to speak with the medical. Again, let me come back here. It does not mean, again, if the patient has got pneumothorax, we cannot still do positive pressure again for them. Because you might also want to speak with the medical team, but it's just like a caution. Speak to the medical team, first of all. Are they happy if I need to do this? What is the treatment? What is the plan for their pneumothorax? Do they want to pass chest drains? Do they want to drain the hair into the pleural space, or have they got pleural effusion on top of that? Do they want to pass drains or anything to help that? If they are on drains, there is no contraindication from me. I can do my positive pressure. And sometimes patient might also be really very poorly. I go to their bedside. I am limited with other treatment techniques. I am now looking at, okay, if I don't really do this positive pressure for this patient will die. Then again, it's going to be risk versus benefit. When I'm saying all these things is, this is what actually make you an acute physio. Sometimes you have to do risk versus benefit. You need to look at your patient and say, look, I am limited. I cannot do manual technique. I cannot do this, I cannot do this, I cannot do that. I cannot do positive pressure as well because of they've got pneumothorax. Then you need to weigh your treatment options. And you know, if you don't help that patient, for instance, to clear their chest, or if they don't go on NIV, for instance, they're going to die. Then we might need to do risk versus benefit. These are reasonings that we want our senior physios to be making with medical team on the ward or in the ITU to support people, to support patients. All right. So what I'm saying is pneumothorax, take a caution. Speak to the medical team. What is the plan for them? It's a red flag. Chances there, if they might have tension pneumothorax, and sometimes somebody can have simple pneumothorax and say, yeah, I'm not worried. And again, you also want to ask them, do I need to put a cap for my positive pressure? Like, do I need to put a cap to the pressure I would have to give that particular patient? Do I need to be conservative in the pressure I'm going to give that patient to breathe? So these are reasonings that you need to be making when it comes to treating patients that are in this category. If that makes sense. Tracheoesophageal fistula, let me look at the chat, but please pop question in the comment sections if you have questions or contributions or anyone. Yeah, Peter Ruben, how do we identify pneumothorax? Yeah, we need chest X-ray to be able to identify these things. Yeah, maybe later on, we might know in this, it's not part of the plan we've got for this training series, but later on we might talk about how you read chest X-ray, what you are looking for, what do you need to be cautioned about, what do you need to be speaking with the medical team, those kind of things. But in answering your question, it's just chest X-ray. You're gonna need chest X-ray to decide that. So other cautions you might need to be cautioned around tracheoesophageal fistula. If somebody has got communication between the breathing tube and between the airway, between the trachea and the esophagus, they are communicating. So the chances there, if they are forcing air into their lungs, those air might leak and go from the trachea and enter into their esophagus. And what is the chance? If you are popping air into someone's lungs and it's going into their breathing tube from the esophagus, you are pumping their stomach. Is that what you want to be doing? No, you don't want that to happen. Because if you are pumping their stomach, again, you might likely worsen their condition. Because if you are pumping air into someone's stomach, you can give them big tummy. What does that mean? You are inflating their tummy. That will have impact again on their diaphragm. We can usually relate this. This is not what you naturally want to be. Again, this could also be a relative contraindication depending on your patient group or depending on where is the fistula. Where is the fistula? For instance, if this fistula is high up here, for instance, and let's say somebody have got tracheostomy, we have had training on tracheostomy. Tracheostomy is down here. Let's give them positive pressure to the tracheostomy. Below the fistula, no problem with that. Here cannot go up, here just keep dropping down. It makes sense. So these are just clinical reasoning kind of things. Again, you can have patient with tumor. Suppose you are being called overnight to see a patient, they are poorly, they are currently on maybe medical ward, for instance. So they've got tumor in their lungs. Do you want to go to their bedside and start giving them positive pressure? Even though, yeah, your aim is to help them to ventilate because they are not breathing well. Your aim is to help them to clear secretions. You want to go to their bedside and start giving them positive pressure. First of all, think about it. If you give them positive pressure, you do not know. You have read in the medical note that they've got tumor in their lungs, they've got this thing in their lungs. You do not know how viable is that tumor. You do not know what is the size of that tumor. And again, if you now pump in here into their lungs, the chances there that the hair can also, hair can escape behind the tumor. Some hair can, it might even, You know, the idea for this positive pressure, if I give you pressure in, I want the hair back out. I give you hair in, I want those hair back out. Some hair might struggle to come out. They might be behind the tumor. And again, you get loading positive pressure. You are pumping hair into someone's lung that they've got tumor in their lungs. That hair might also be, dislodge some of these tumors as well. This is not, they might be bleeding. You don't want bleeding, blood inside the lung. This is not what you want. So you might want to take caution. Again, this could also be relative contraindication, depending on how you think about this thing. Imagine if somebody have got tumor in the upper airway, high up here, let's say high up here, for instance, and they've got trachea again. I am not worried. I can give them my positive pressure through their trachea. If that makes sense. Again, if somebody have got tumor high up here and they've got ET tube, the breathing tube that goes through from the mouth into their lungs, if they are on that and their tumor is high up, I am not worried. I can still give them my positive pressure. If that makes sense to somebody. But if somebody have got breathing tube and their tumor is inside their lungs, like in the alveoli, do you want to do that? No. So again, I will not say no, I will not say yes. But because you have to, you might also need to weigh your options and speak with the medical team regarding these things. But these are just cautions, something you need to be aware of. Oh, I say it, I stop. What do I need to do? Do I need to speak with my senior? Do I need to speak with the medical team? Have you weighed risk and benefit of why I must do that treatment against if I don't do that treatment, what is going to happen to them? All right. Again, severe hypotension. You might have patients, their blood pressure, their systolic blood pressure is very, very low, 80, cardiovascular instability. Why? So if I give them positive pressure, I want to push this to us. What do you think might likely to happen to this patient? Somebody is severely, like their blood pressure is low, really low, and I'm thinking of giving them positive pressure, either NIV that covers this, IPPV, whatever, any of them. If I give them positive pressure, what do you think might likely to happen to these people? Can I get some response in the chat box? I know these are looking very, very unfamiliar, but like I said, I will do my bit to build some concepts. We'll still come back again and again to discuss these things because they are really, really very important. So what do we think? What do we think? I think I've explained some of these things when I was talking about, I think TB high in the past. Anyone? Anyone? Are we there, please? Hello? Hello? Oh my God. Am I speaking to myself? Hello?
No, sir.
Yeah, all right, thank you. So what is going to happen? Yeah, okay, thank you, thank you. What is going to happen? So the idea is this: if you give somebody positive pressure, what you're going to do is, if I inflate your chest, don't forget in the chest, you've got arteries, you've got veins, you've got the heart, you've got everything in the chest. So if I inflate your chest, what I'm doing is I am forcefully bringing your thoracic region to be, to be expanded, might even be maybe slightly above your normal. So what I'm doing is I'm increasing the interthoracic pressure, positive pressure. I'm increasing your interthoracic pressure. If I'm increasing your interthoracic pressure, that might have impact on your cardiac output. That might have impact on your myoarterial pressure. So that might further drop your blood pressure because the blood that will be returning back to the heart. If the cardiac output is low, the venous return back to the heart, that back to your right atrium is going to be low. So what is going to happen to your myoarterial? What is going to happen to your overall blood pressure? It might be low as well. Think about that. So that means if I'm going to see a patient, I have been called, I'm the on-call physio, or somebody have been admitted on the ward, in our unit, in our neuro ward, or medicine, or surgical ward, wherever they have. I'm thinking about, oh yeah, I need to escalate my treatment, and this lady is really, really very poorly. And it is my responsibility to also look at their blood pressure, look at their respiratory rate, look at their hearts, look at their NITU score. Am I happy with those writers? Think about it. Am I happy with those things? And start correlating things in your head. Oh yeah, if I do this for them, oh, the blood pressure might drop. So if the blood pressure drops further, what is it going to do? or you know the implication of what might happen to them. So have you spoken to the medical team first of all? This is not like absolute. No, you can't do it. No. Have you spoken to the medical team? Is there any fluid that we can give to this patient just to top their blood pressure for the sake of physio you want to do for this patient? Have you spoken with them? Yeah, again, another group of patients, you might find patients on high allotropes, metramine, adrenaline, epinephrine, patients on blood pressure medication, infusions, patients that are infused. Maybe you can find all these in step, maybe ITU patients or patients that are being stepped down from ITU, for instance, that are on infusions, blood pressure. You don't just go to their bedside and you start doing physio. This is wrong. This is acute hospital. You need to look at, oh yeah, what attachment have they got? What is that thing running in the attachment? Oh, is it what infusion is this? If you are unsure of anyone, ask questions. Ask questions. Ask the nurses, what is this for? And again, ask questions. For instance, now let's somebody is on metramine 3 mils, for instance, and I want to do some of this positive pressure for them. Yeah, I know metramine is to support their blood pressure. Maybe at the moment their blood pressure is on, maybe it's systolic 135, for instance, with metramine 3 milligram. Now, I know that if I give them positive pressure, their cardiac output might drop, their blood pressure might drop. If that blood pressure drop, where are we going to go from there? Well, I can't hold it. I've not got anything to hold it as physio. Where am I going to go? So you need to speak with nurses at the bedside first of all. Yeah, I'm thinking about this for this patient. I know they are currently on infusions, blood pressure support. If their blood pressure drop, is there any scope? Is there any scope to titrate their blood, their fluid, their infusion? You ask them those questions. Some people might say, oh, we are the ceiling for that blood pressure. If they tell you they are the ceiling, and in your head, you are looking at the starting blood pressure. Oh, the starting blood pressure is, let's say, 100, for instance. Starting blood pressure 100 is, I might be like, oh, if I do this thing, what if the blood pressure starts dropping? What am I going to do? Think about these things. And sometimes you also need to weigh the risk and benefit of whatever you want to do for them. Why do I really need to do these things? If I don't do it now, what is likely to happen to this patient? All of these things I've written here, they are just clinical reasoning kind of things. They are not like, absolutely, you can't do it. No. There's nothing like that in acute hospital. It all depends on how you can think. It depends on how you can reason. It depends on your patient in front of you. It depends on who do you want to treat at that moment and why. And you should be able to justify why you are doing certain things. Because we know if you are treating patients that are really, really poorly, don't do some certain physios for them, they might back, they might not make it. Think about all of these things. So yeah, another one, captivating lung disease. I know why I'm really, really spending time on this part, because it's really very important. It's not to cram book, it's not to cram. In fact, if you crammed it, you're not going to be a good physio. You need good understanding of why do I need to do this? Why don't I do this? Why is this important? Now, captivating lung disease, it could be maybe patient with active TB, for instance, tuberculosis, or maybe patient, maybe they've been admitted, maybe for instance, in ITU for a long period of time. They are struggling with viral infection or fungal infection or whatever infections, and those infections have been hitting into their lung tissues. Now there is like a cyst, like a pouch in their lungs. So I know if I pump air into their lungs, in the aim of helping them to clear their lungs, some air can get trapped. Just like tumor, some air can get trapped behind the tumor, some air can get trapped. And again, some air can also make that cyst to be bigger, or maybe maybe just make it burst or something. And if you make it burst, or if you just pop, something like that, what can happen is some air can also find their way into their pleural cavity. And indirectly, patient cannot, or directly or indirectly, patient can also get pneumothorax. You don't want to go into that link. Remember what I explained on that pneumothorax. So you also want to be careful about captivating lung disease, or patients that have like five structures in their lungs. So you want to be careful with them. So you are looking at that. So meaning, if I'm going in to see patients that are acutely unwell in acute hospital, it is my responsibility to screen their notes, read their notes, understand their medical background. Where are they coming from? What are we actually treating them for at the moment? Look at their diagnostic. Look at their tools. Look at the CT, the chest X-ray they have read, they have done, and make sense of those things. Make sense of those things to formulate your clinical reasoning. This is physio job in acute hospital. These are your job in acute hospital. All right. Another one, recent upper airway surgery. If somebody have got oesophageectomy, we have had surgeries in the past. We have talked about those surgeries, oesophageectomy, removals of esophagus. I might want to be careful. Or somebody have got oesophageogastrectomy, esophagus, lower part of esophagus and upper part of the stomach. If you've got a surgery around that part, I want to be careful. Why do I have to be careful with my positive pressure? It does not mean 100% I cannot do it if I need to do it, but I need to be careful. I need to speak with maybe the consultant that did the surgery, first of all. This is how you think. I need to speak with the consultant first of all, because I know if I give them, my aim is to pump air into their lungs, give them positive pressure, and yeah, some here can also get leak and go into the breathing tube. Don't forget, this patient has got oesophageectomy surgery. Okay, and again, you can destroy the chances there that if the air get leaked, you're going to destroy the good job the surgeon have done. The anastomosis of the surgery, you're going to you can get it separated. You don't want that. So you want to be careful. So do you want to speak with who did the surgery first of all? Do you want to speak with them? Oh, this is my patient. They are being poorly in bed. They are struggling with this and that. I am worried if I don't do this, this might happen to them. They will reason with it. Not like you want to meet somebody, you don't even know your job, you don't even know why you are meeting them. No, they can't make decisions. They don't know physio. That is what I keep saying. I have said it in the past. I'm going to say it again today. Sometimes we blame people we are not supposed to be blaming. We blame people for not sending you referral. Do they know physio? They don't know physio. They are not physio. We are physio. So you go to meet them, you tell them, this is why, this is this, and this. I'm worried if I don't do my treatment, this might happen to them. If I do my treatment, I'm also worried at the same time, here can get leaked and destroy the anastomosis or dislodge the anastomosis. They might say, yeah, I'm more worried, no problem with that, risk versus benefit, do your treatment, great. And somebody say, yeah, let's put a cap with your pressure you want to give them. Let's be conservative with your pressure. Somebody even say, yeah, are you thinking about, yeah, because sometimes, for example, now, if somebody have got, what is it now, maybe lobectomy, for instance, sometimes in the theater room, they test the anastomotic, like they test the integrity of the anastomosis. They even test it with positive pressure. Sometimes in the theater room. It could be the case of this person as well. So if maybe they've been tested with 20 centimeters of water or something, I say, yeah, we are happy with 20 centimeters of water. That's fine. Go to that bedside, do your treatment. No concern. So let's think about all of these things. Where are we in all of these things? Where are we in all of these things? So we need to be doing our job. Okay, frank hemoptysis. Oh, somebody bringing out blood. We don't know where the blood is coming from. Is it coming from the alveoli? Is it coming from bronchi, right or left? We don't know. We don't know. Yeah, even though they might have do some scan and say this is, but again, I want to be careful. I'm reading their notes. I want to be careful because I know if I give a positive pressure, that can make that bleeding worse, or any healings or whatever that is trying to go on there is going to disrupt the healings. I want to be careful. Okay, you've got again emphysema, bullous emphysema. If you've got a patient with severe COPD, you look at their chest X-ray, you look at medical documentation, the radiographical report, and you said you can say they've got bulla emphysema. What does that mean to you as physicians? I want to be careful. Nobody will prompt you for all this. These are your job. You should look at it and say, yeah, I'm not going to do this because of this. I'm going to do this because of this. Is your job. Yeah. Why am I worried with that bullous or bulla, whatever? I am worried because I know if I give positive pressure, some ear can get trapped. One of the bullae can also get popped. And if you get popped, what happens? Ear link into the pleural cavity. You can give them pneumothorax. Think about these things. I don't want that. And again, you can even do because that bulla already, they have been distended, they are just floppy or something. They are prone to just popping. You don't want hair to be trapping there. You don't want that. You don't want them to get popped. You don't want to give your patient tension pneumothorax. Think about all these things. And again, these are not absolute. Like, no, I cannot do it. No, sometimes, again, if I need to do it, I need to be speaking with consultants. We need to sit down and say, yeah, this is where I'm worried with this patient. This is where they are. This is my treatment, I'm limited in this. You take your treatment plan with them. I'm limited with this. I'm thinking, I can't do mark. I can't do this one. I can't do this. I can't do this. This is what I've got at the moment. They are dying. We need to do something. Physio need to do something. Think about all of these things. Again, if I need to do it, I might think about, oh yeah, let me lower my positive pressure. Don't forget, you are giving patient 2 sets of air. Air that goes in, positive pressure. Air that comes out, negative pressure. Yeah, I am not worried with the air that are coming out. If I need to be conservative, or if I need to cap any air that I want to give them, it has to be air going in. And I want to say, oh yeah, let me start with low air, like low pressure going in, breathing in. The breath I'm going to give them, let me be conservative with my. If this thing makes sense to somebody. I know these are concepts we are not familiar with, but I'm just doing my bit just to make it more very, very understandable for us. Yeah, again, if you got patients severe bronchospasm, let's say, for instance, you got asthmatic patients, asthma, you have to be careful, treatment-wise, physio-wise. When it comes to treatment asthmatic patients, you want to take caution with them, because you know anything you do can irritate their airway. Because if you are giving, I just explained now, you have 2 sets of air here going in, here coming out. You are shifting air in and shifting air out. For asthmatic patients, you're going to irritate their airway. You can worsen that bronchospasm. You want to be careful. Absolutely no positive pressure. Absolutely no positive pressure. Be careful with them. And again, bronchospasm again could also due to some other reasons. It could be sputum plugging. It could be inflammation. Some people might just need bronchodilator. Some people might just need to be on corticosteroid, for instance. If it is not asthma and you've got bronchospasm, all I just need is, doctor, give them what is it? Give them bronchodilators, salbutamol, tiotropium, I'm fine. Once that is okay, I can do my positive pressure. So you need to get that clinical reasoning right. You cannot just look at the clinical medical notes and if you have past medical history, bronchospasm, or somebody have just documented now, they are standing, they are just whistling and something, and you are thinking, yeah, bronchospasm, yeah, no, I'm not going to do anything. What are you doing? What are you doing? What are you doing? They are not getting that clinical reasoning right. They might just need bronchodilators. They might just need to be on the bronchodilator, for instance, and yeah, they're fine. And if it is asthmatic patient, they might also be on the same medication as some might even be on magnesium, for instance. But you want to be careful with asthmatic patients, because you know the more you shift air in and shuffle air out of their lungs, that might make their constrictions, bronchial constriction worse. Be careful with them. Yeah, recent lobectomies, recent pneumonectomies. Somebody have done one of the lobes or the lungs being removed. Yeah, we have a lot of patients here on that category. Yeah, what do you want to do? You want to be careful. Now, if they remove one part, they're going to just do anastomote the other area of the lungs together, making neat and clear. You don't want to go there and just give them here pressure that will just dislodge everything. You don't want to do that. Because if you do that, you're going to destroy the good work of the surgeons. And aside from that, you're going to make them bleed. You want to make patients bleed. You want them to bleeding into their lungs? No, you don't want to do that. Again, that does not mean I cannot do it if I need to do it. But I know in my head, I need to speak with who did the surgery first. I need to be speaking with them. Yeah, I need to clear it. Yeah. Do I need to cap my pressure? Do I need that? This and that. Are you guys happy? They might even say, like I mentioned, they might say, yeah, we've tested it. This is fine. Yeah, do your positive pressure. No concern. Great. Blast them. Do your stuff. Done. Yeah, unstable spinal fracture. You might find patient unstable spinal fracture. Yeah, again, it might not necessarily mean I cannot do it. They might just need some level of stability. Maybe they need cooler, maybe they need TLSO, maybe they need anything. If I need to do it. And again, if you medical team, even without all of those things, somebody can manually stabilize them if I really have to do it. So these are decisions you need to be thinking about, weighing risk versus benefit. Look at your patient. It's just case by case based. It's based on your patient. Look at the patient and good communication between them. I normally say this, and I will say this again. Fighting you, fighting me, I fight this is just endangering the life of our patient. You cannot be a great physio handling acutely unwell patient without other MDT. And they cannot also operate well without you. So this is where good relationship comes into place. And you, as a person, as a physio, as your job, getting your clinical reasoning right. And if I'm having any discussion with anybody, I need to, in my head, I need to know what I'm discussing with this. All right, if that makes sense. Are we still there? Do we have any questions? Is it making sense? Are we getting some concept? Hello.
Yes, sir. We are, sir.
Thank you
We
very
are with
much.
you, sir.
All right,
Yes, sir.
thank you. I appreciate that. Yeah, great.
Yes, sir.
Thank you. Let's continue. Cool. All right, so I've decided to put these things into writing just to make it more easy for us. If I send the slides, then you can easily relate to what I've explained. And again, I think all these things will be recorded. You can listen and listen again so you can understand the concept. Yeah, this is the aim of these things. So the other ones, yeah, I've not explained is peak airway pressure. I'm not sure we can reach that side of ventilator. I really want to sit down and talk about ventilator, but let's just build concept. But this is just, there are some contraindication as well, but let's just keep it that way now. Okay, before I go, yeah, I'd like to talk about ICP because I remember I have mentioned we have some discussion around traumatic brain injury patient. And we have mentioned, we have explained again, I think we explained that time that some patient might be on ICP monitor, they might, ICP boat, they might, what is it again? They might even, the medical team might even like set their ICP protocols. They want oxygen to be this, they want CO2 to be this, blah, blah, blah. If you go over those things, they are there. As physio again, if I need to go to their bedside, this is patients, they are on street, we call it neuroprotective. These are neuroprotective patients. You go to their bedside, they are on ICP monitor. Now they are being poorly, they are standing crackies, rattling chests, evidence of secretion here and there. Yeah, if I need to do my positive pressure with them, I can do it, but I need to look at what is the baseline of what am I working with? What is the baseline of the mean arterial pressure? At the bedside, I need to look at the screen and find what is the mean arterial pressure. What is the blood pressure saying? Are they on blood pressure support at the moment? Before I do any of those things, what is the ICP itself? What value is it? Then I need to be speaking with the nursing staff. How are they normally? How are they responding in terms of when they do suctioning? How are they responding to that? In terms of when they roll them, well, when they just reposition them in bed, how are they? Then I might just say, yeah. Because I know again, why am I checking all of these things with the nurses, or why am I looking at the monitor to look at this parameter? Why? The reason being that, again, if I just go there, blast them with positive pressure, I know that positive pressure can also affect their hemodynamics. It can make them to be cardiovascularly unstable. Because I know from what I've explained, if you blast them positive pressure, it's going to increase the interthoracic pressure, cardiac output can drop, mean arterial pressure can drop, venous return back to the heart can drop as well. And if that happens, what that means to ICP patients, from patients that have been neuroprotected, what that means to them is cerebral perfusion pressure might drop. You don't want that. I have explained this thing. Please go back to those TBI, these things to relate all of these things. You don't want that. So that means, what that means, if the patient is on ICP protocols or ICP monitor or whatever, positive pressure is not something I want to routinely be doing with them. I need to be clear. There is need for clear evidence of why I really want to do that with this kind of patient. If that makes sense, I need to be really, really clear. There must be evidence. Like I meant, even regular normal functioning is not something you want to routinely do, because I have explained when I was explaining TBI, functioning can irritate their airway, it can worsening, it can affect their cerebral perfusion pressure, ICP, all those things. I have explained those things. Go back, but each one can impact that as well. So you need to really, really clear. And sometimes again, you also need to do risk versus benefits. Again, you know that if you don't help, if they are on ICP monitor, if you don't help them to clear their chest, if they are standing cracky, they've got rattling chest. If you don't help them to clear their chest, what is going to happen is they will retain CO2, because they will not be ventilated well. They're going to retain CO2. And if they retain CO2, what is the link between CO2 and ICP? I've explained that in the past. CO2 is a vasodilator. It's going to dilate the cerebral vessels. It's going to increase the ICP, which you don't want. And again, remember I explained what is the implication of increased ICP. You can get brain innervations. Brain can start coming out from the, what do you call it? Brain stem can start coming out from the foramen magnum. You don't want that. Somebody is dead already. So think about all these things. So our job in acute hospitals is really, really very important. And we need that sound clinical reasons. Why we'll be doing certain things or why we are not doing certain things, if that makes sense. All right, let's continue. I'm not going to go through the slides. Some of them are just repetition of what I've just explained. All right, flare chest is also there, but flare chest again, maybe I just mentioned it. Flare chest again, it is not absolute, but you need to be careful because I know if I blast you with positive pressure, I put air into your lungs. If I need to shock the air out of your lungs with the secretions out of your lungs, for instance, the flare region, the region that are being flared, let's say for instance, somebody have got flare segment on the left side, that part can get shocking as well on expirations. I want to be careful because that might puncture heart or lungs. But again, that does not steal me. If I really have to do it, I cannot do it. All these things are just questions. Weighing your options, look at your patients. How are they presenting? Why do I need to do this? Or have I get some like compliments from other treatment techniques? Looking at my toolbox. Look at my toolbox. Do I really have anything else I can do with them? If those things are not working, then I might be thinking, okay, do I need to augment that with something else? This is how you think as physio. Physio should not be programmed. Oh yeah, like I used to say, not every back patient that comes to the hospital ideally should have infrared. Not every back pain that comes should have ultrasound. There should be a reason why we are doing all these things for them. All right. This is why we are physio. This is why we are clinicians. This is why we are not technicians. All right. Let's continue. Okay. So this is practical checking our knowledge now. And I really want us, please, I really want us to participate here. We're going to just quickly run through these things, just a bit of what I explained, just checking our general knowledge of portions now. Okay, please participate. Let me quickly look at the chat box. Some people have written something there. Okay, yeah, QV mismatch. Yeah. We are here, sir. Thank you. All right, let's look at this first one here. We are just checking. Suppose you've got this patient on, you've got this patient in your hospital. You are the most senior physio. The first one says, this patient have got bronchospasm. So they collapse. Maybe they collapse somewhere at home or somewhere. Some good set of people, they did CPR, which is nice. Yeah, they did CPR to resuscitate them. In the process, some of their ribs were broken, or we are not even sure. Either their ribs were breaking, like that was the question mark, like querying ribs fracture. So they did, but what we know from the medical note is, oh yeah, they've got bronchospasm. Recent CPR, they did CPR. We are in our head, we're gonna be like, yeah, oh, they might have broken some ribs, they might not. You are thinking that way in your head. And this same patient, severe hypercapnia, their CO2 is really high. Okay, they've got emphysema, they've got bulla, they are currently having chest drains, thoracic drains. They have chest drains at the moment. So what in terms of cautions, what are you thinking about for this first patient? In terms of caution, or if you need to just give me, okay, let me give you some of the toolbox now that might be available for all of these things we don't need to discuss here. Suppose positive pressure. We don't know. Just say positive pressure for now. We're going to dive in very shortly. Positive pressure. Manual techniques. Manual techniques could be doing stuff in their chest, doing stuff in their abdomen. Manual techniques, two things. You can do stuff in their chest, you can do stuff in their abdomen, and you have positive pressure. Let's just look at those three treatment toolbox that we've got now. For this first patient, what are you thinking about? Bronchospasm. This first patient has bronchospasm. They did recent CPR with them. Severe hypercapnia, emphysema, bulla, intracranial chest, chest drains. Let's call it chest drains on the left. They have chest drains on the left. So what are you thinking about for this patient? Manual techniques, chest, abdomen, positive pressure. Any cautions for anything? Anyone here, please, please, please. Guys, I need our participation here, please. Sorry. So yeah, so what do we think for this first one? Bronchospasm, what comes to your head? What are you thinking that, yeah, I might not be able to do with that? For CPR, what are you thinking that I might not be able to do with that? Bula, what are you thinking that you are not be able to do with that? Please, guys, drop comment, open your mic. Let's talk about these things. This is really advanced acute physio care. So, so let's talk about these things. This is why we are here and why we are physio, acute physio now. All right. This is a gentle lady waiting for physios. Everyone is waiting for you, senior physio. Everyone waiting for you to do something. This lady is standing chesting, lung collapse, everything, blah 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 with her. We are waiting for physio now to do their stuff, to do their magic. So what, and what? I've mentioned 3 treatment toolbox now. You can do stuff with their chest. You can do stuff in their abdomen. You can do positive pressure with them. Okay? Which do you think might be applicable? Or what do you think, oh, I might not be able to do this one because of this. I might not be able to do this one because of, let's just build some clinical reasoning kind of things. Forget about what you want to be doing in their chest. Just know that you can do manual skills in their chest. You can do manual stuff in their abdomen. Forget about whatever skills now. But let's look at clinical reasoning kind of things first of all. Because I don't want to go to their best and make them worse. Give them what they don't have. Or break like 4, 5, 7 ribs and say, yeah, I've done physio. What are you doing? Yeah? So what are you thinking about? Guys, are we here, please? Are we here? Or I'm just doing my thing for myself.
Yes, sir. Yes, sir.
All right, thank you. So what do we think?
For bronchospasm, I want to be careful with positive pressure.
Good.
Then the fact that they suspected rib fracture, chest techniques, not absolute contraindication, but if not necessary, I want to avoid it.
Cool. Yeah. Right on.
Then severe hypercapnia has already a tendency of increasing the ICP. So adding positive pressure to them might escalate that risk.
Okay. Cool. Lovely. Yeah. How about Bula and emphysema?
That is what I can think for now.
Okay. All right. Thank you very much, PT Ajora. That was really fantastic from you. Thank you. Absolutely genius. I love that. Yeah. Thank you for that. Yeah. Any other person, you can pick any of them. We've got like I think I've put a lot. We might not be able to go through everything anyways, but it's just clinical reasonings. Because ideally, in your head, when you are reading the note, you are picking those red flags and you put them in your note, cautions. I normally put them cautions. I will leave them out. So that subsequently, my yeah, so that subsequently, if any other physios, or it could even be any of the senior physio doing that for you, you just go to the best, just read their note and say, yeah, caution, they've listed everything out. That is nice. If I do that, you that are coming to treat after me, you can easily look at it and say, yeah, we are cautioning about these things. And it is you that have done that. Yeah, I will just look at it and say, yeah, we are cautioning about these things. You have saved me some stress or energy I need to, reading through the note and picking up where I need to be careful with. So all these things are just saying why we need to be really careful handling patients. We are not programmed to just go and do things. We are programmed to read, formulate clinical reasoning and admitted expert treatment to our patient. All right, just like he has mentioned, bronchospasm. I want to be careful. Oh, bronchospasm. Is it coming from Is bronchospasm coming from asthma, or is it just mucus plugging? I'm thinking in my head. If it's asthma, just like I explained, I'm to say no, 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 no. Yeah, if it is bronchospasm, they might just need normal bronchospasm, like mucus plugging, like just secretion driving or anything. I can just say blast them bronchodilator, my friend. Give them intratropium or give them salbutamol nebs or whatever things to open their airway. Then I'm fine. I'm fine with that. But yeah, but I need to sit down first and find out what is driving this. Recent CPR. Oh, I might want to be like, oh, ideally, if I need to do stuff in their chest, like maybe percussion, shaking, expiratory beeps or something, or vibes, whatever you call it. And I want to take caution on that and say, don't break someone's ribs. Ideally, you might just find it as they have done CPR in your head. When somebody is giving you hand over and saying somebody has done CPR, you are not just hearing that, oh, CPR, CPR. Link it with potentially if I need to do certain things, then I need to be careful. Yeah, that's just it. I don't want to repeat what some people know. Again, if I'm doing my expiratory part, chance is there that, yeah, the ribs at the moment might be maybe vulnerable to fracture, or some people might even have fracture. Think about that. Until we see maybe chest x-rays and we say, yeah, all this is fine. Yeah, that's fine. Yeah. Bulla, emphysema. Bulla, like I explained, Bulla, I want to be careful. I don't want to give them positive pressure and everything end up being, and you bust the, what is it? You bust the Bulla. You want to give them pneumothorax? No. It's area where you don't want to end up being as physio. Think about that. Now, but again, they have mentioned that they've got chest drains. That chest drain means, oh, maybe chest drain for what? You have to clear that. Is it for pleural effusion? Is it for pneumothorax or hemothorax or whatever? But whatever it is, they are on chest drain. I am not worried. That alone does not stop me from not doing my positive pressure. Being on chest drain means, yeah, it is patent. I can do whatever thing I want to do with them at the moment. It does not stop me. If that makes sense. But for these patients now, look at their chest. I have concern with their chest. Look at their lungs. Blah, 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 blah. I'm thinking about positive pressure. But the abdomen is free. I can still do stuff with the abdomen if I really want to do things. But if I think about, oh, now I'm marking the abdomen, I'm doing abdomen mark, they are not clearing well, maybe they are being sedated, ventilated at the moment, whatever. And I think about, oh, this patient really, they've got a lot of junks in their chest. We really have to clear these junks. And I'd be like, yeah, I need to speak with the medical team. On what reason? On the criteria of that Bulla and emphysema, we need to have discussion and say, yeah, do I really need to do this? We need to think together. If that makes sense to somebody, this is how you think for patients that are acutely unwell. We go to second one. Second one quickly, please participate, guys. Second one quickly, few minutes. What do we think about second patient? TBI patient, we have done stuff on TBI. ICP both monitoring, they are on metramidone, NORAD and adrenaline. Those medications are for blood pressure support. What are you worried about for this patient? Sharp, guys, time is going. What are you worried about? Hello, who is there? Hello? Hello? Physios? This is our patient, please help, do something. What are we worried about? I think I just explained something about TBI not quite long now as well. And I think I've also spoken about blood pressure kind of medications and all those kind of things. So what are you really worried about this patient? What are your worries? What are your concerns? What are you concerned about? Who do you want to speak with? Hello? Who is helping us? Yeah, like I explained, because of time, again, this one, metramidone, blood pressure, adrenaline, blah, blah, blah. This shows that they are currently on high anotropes at the moment, high blood pressure support at the moment. Oh, I know that if I go in, give them positive pressure, without speaking with the nurse, what is the ceiling for their metramidone? What is the ceiling for NORAD or adrenaline? If their blood pressure drops, do they have any scope to titrate their blood pressure up, the fluid they are giving them? If they don't have those scope, then I need to weigh my options, risk versus benefit kind of things, before I do anything with them at the bedside. But again, if they are really cracky, sounding cracky, you need to weigh the risk. And the ICP is really going high because of the CO2 they are retaining, because they are not getting ventilated where they can puff out CO2, because of the secretions, the vacuum, there's vacuum is mismatching, just like somebody have written in the chat box. So I might think about, yeah, do I really have to do this? Now, if I really want to do it, because of the blood pressure support, I might think about, yeah, if I need to puff air into their lungs, I might want to maybe cap that pressure so that the chest rise that will actually cause the blood pressure dropping will not be too much. This is just clinical reasoning kind of things. This is clinical reasoning kind of things. Okay? And again, I might also, you have spoken with the nurses. Think about that before you go in. Ask them. And again, if they have, look at your starting blood pressure. This is what I normally advise. Look at your starting blood pressure. Look at the other thing, mean arterial pressure. What is their cerebral perfusion pressure at the moment? Are they stable? Observe first of all. I will just look at it. Observe first of all before you start doing anything. This is clinical reasonings. Okay. Let me look at another one. Blah blah blah. Okay, look at this one because of time. Facial bones, sounding chesty. This is on the ward. This is a ward patient on elderly care ward. This is the elderly care ward. They are sounding chesty. They've got currently on 40 liters of O2, maybe via venturi mask. By now, you should be able to relate all of those things if you've been following. Venturi mask, they've got refracture. What are you worried? What are you worried about at this moment? Like in terms of three toolbox, three treatments in your toolbox. Chest, you can do stuff. Abdomen, you can do stuff. What is it now? Positive pressure. Three treatments modalities you've got at the moment. They have facial bones. They have refracture. They are 40% FiO2 and they are not saturating well. You're going to leave them? You can't leave them. You are not doing your job. You are leaving them. So you need to do your job. This is where you are being employed and being paid for. So what are you going to do? Everybody is there. Doctor is there. They are waiting for physio to come and do their magic. What are you going to do? What are you going to do, guys? What are you worried? We are just looking at caution now. What are you worried about? And why are you worried about certain things? Or anyone, please. I really want us to know. There are a lot of them, but I can't take everything because of time. I have every other thing to discuss. But these are ways to build clinical reasonings. It is not by reading a lot of books. It's by speaking with maybe colleagues that are doing certain things, drinking from their wealth of experience, sharing knowledge with people, speak up. There is no right or wrong. Just speak. Speak whatever comes to your head. Listen to them, modify yourself. Yeah, that's how this thing happens. Yeah. So what are you gonna do? Elderly man, currently on 40% FiO2 via venturi mask. They are desaturating. They are sounding chesty and rattling, and they've got facial bones. What are you going to do? And the idea that, yeah, I'm not a cardiophysio, it does not, I don't think it really is something we need to also, separating acute from, like I used to say, from outpatient. If you are in acute neurophysio, you need respiratory competence. You need to be respiratory competent. If you are trauma neurophysio, this is trauma. This patient is going to be, this patient is currently on the elderly care ward. So the physio there should be just competent. They should be able to see this patient. You don't have to be cardio. There is no cardio anywhere. If you are neuro, you should be chest competent. You need to treat chest. If you are, because you will have neuro patients that are chesty. So you should be able to do your stuff acutely, treat them acutely. So this general thing that we do. So we need that separation. Outpatient, being outpatient, community, be community, then acute neuro, acute surgical, acute respiratory, elderly. Yeah, this is what we want to get some of these great clinical reasons. Until we are able to do that, then this thing will start making a lot of sense to us. But let's do what we can do now for now. So what are we going to do? What are we worried about in this patient?
The facial bone. It can lead to inflammation of the upper airways and lead to obstruction of air into the lungs. Then sounding chesty with rib fracture in an elderly patient, their bones are fragile, so have to be careful with the manual techniques.
Mm-hmm. Yeah, perfect. That's it. It's as simple as that. Thank you very much, P.T. Stella. That's really great. So now I know this is an elderly patient. Already they have a fracture. Maybe they had a fall or something. Now they have a fracture rib. It's going to be painful. At the moment, it's going to be really, really very just rib fracture. If you are seeing patient in a lot of patients, you will know that this thing is really very painful. When they take in deep breath, problem. If they need to cough, problem. Because breathing is everything that we do every time. So a lot of people will be in pain. So do you want to go to their bedside again and start jumping in their chest and do percussion checking kind of things in there? You want to look at that and say, elderly patient, rib fracture. And again, rib fracture, we don't know this question is not being specific. If this is what it has been written, but you just want to, is it right ribs? Is it left ribs? Is it ribs 1 to 2 or 2 to 5? You have to be definite. Look at it. This is very vague. That's why we want to break it down. What side? What distinct? Is it flare ribs? Is it stable? Is it unstable? Break those things down. Very important. Because you need those things to make your decision for this gentleman. And again, just like you said, elderly patients, some of them might even be on steroids, prednisolone, blah, 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 those things. But if it is background COPD or blood, they might be on steroids. You want to start going down, jumping in their chest again, you have to be careful. Weigh those options. These things are not absolute. Again, it does not seem me that because they are elderly patient, I cannot study if I need to do it. But I need to also put some things into context. I love that clinical reasoning. Put it in the context. I don't have elderly patient. I'm not going to fracture their ribs like this. Again, somebody chest pain and rib pain. If I do it now, think about those things. Facial bones, positive pressure. Just like you mentioned, some people might even be having inflammation of the upper airway, blah, blah, blah. Oh, yeah, good one. Good clinical reasoning. And again, if I need to give people here, I need to just think about it. If I need to put here into someone's lung, I'm bringing one device now. There will be an interface between the patient and the machine. Do I still want to put face mask? Think about these things. That face mask, somebody with facial bones, is that not going to affect the inflammation, blah, blah, blah? This is how you make reason and now decide what would be the best for this patient now. And what is going to be the best for them? Again, look at think about it. Now, for facial bones, I might think, okay, do I need to speak with the medical team? This patient, how are they presenting at the moment? Can they still follow instruction? And their upper airways, there is no significant inflammation or anything. The outer airway is fine. Do they need mouthpiece to get their positive pressure if I need to do it? This thing can also be facial fracture. Imagine patients that have fracture in their face or facial fracture, the bones in the face have been broken. Do you want to put mask again to further dislodge that bones stability of the bone? You don't want to do that. You want to think about what do I need to do if this positive pressure? What other things do I have in my toolbox? So I'm thinking about that. Okay, the abdomen of this gentleman is fine, but at the moment they are latent, if they are alert and awake, the problem might be that they might struggle to tolerate that mark. If you need to mark them, you are now weighing your options. Okay, if they are not clear anywhere and I need to put MP airway in their nose, do I just go there and put MP airway? Somebody that have facial bones, facial fracture, something. I need to speak to somebody first. Or somebody that have base of skull fracture. Do I need to, even if I need to do something, just start now. I will now go to the best and start feeding my suction through their nose. Somebody facial base of skull fracture. How about if your catheter your catheter just miss the road and start going into their brain? Think about all of these things. This is how you make clinical. Facial base of skull fracture, facial fracture. When it comes to suction, because these are skills physio also need to develop. I might be thinking, okay. I may not be able to do suctioning via their nose, or maybe put positive pressure with mask or something like that. You are thinking that in that lane, and you are thinking, I might need to speak with ENT doctor first, or whoever is leading their care. The consultant, what are they for? Are they for conservative? Are they happy for me? If I try, because this patient is sounding chesty now, 40%, before you know, they might go 60%, they might go 80%, they might start getting tired, they might get fatigued. Where do we go from there? We need to help this gentleman. This is how you are thinking. Okay, this is how you are thinking. And you go to, this is the option I've got. I am limited because of this. But are you guys happy if I try this? because of this, because they are getting poorly. You have reasons to back your. There is nothing that is absolute in hospital. It all depends on what is the patient, what is the patient presentation at the moment, and what are you doing, and what have you got in your toolbox? What is your clinical reasonings, and how are they presenting? Think about those things. Let me just look at the one I've not mentioned. Yeah, look at this one: TBI, facial fracture, base of skull. Yeah, I think you can relate with all these ones now. Base of skull fracture, facial fracture. They've got apical pneumothorax. You should be able to relate that. Liver lacectomy, liver issues, blah blah blah. I think if I need to do abdomen, there might be issue with that. Mesenteric contusions, I'm not worried with that. Left hand, fourth, fifth, metatarsal. If I need to do mobility, that's when I need to start worrying about metatarsal fracture, all these things, getting their weight bearing status. This is how you think. Somebody with C7 fracture, blah blah blah. Am I thinking C7 fracture? If I need to do manual techniques, this might be a content. Won't I dislodge the stability of their fracture? Think about that. Speak with the TNO, trauma and orthopedic doctor first, consultant. I say, yeah, this is my patient, this is my worry. If I do this, some might need to be on brace, some might need manual stability, some might need anything, and some might, they might use that we are not worried. This patient will die. Risk versus benefit. If you don't do your chest physio, this patient will die. And I need to do that. Priority. Think about all of these things. I've got a lot of them. You might not be able to go to all of them anyway, unfortunately, but it's something when I send over the slides, do yourself good to read over these things to build your clinical reasonings. And if you do have any questions, pop them to me. We are happy to discuss them. Yeah, I love to talk about this one. Pulmonary fibrosis patient on medical ward. PF patients or cystic fibrosis patients, they are on your medical ward now and they are standing chesting. What are your worries? From positive pressure side of view now, what are your worries? Let's be direct because of time. What are you worried? What are you worried about? Anyone? And why? These are what we get on a regular basis. You get, if you are in specialist center, big hospitals, where patients are being admitted, and you are really keen on doing your job. Like, you will get all of these things. You will get to see them live. Because there is no way this patient can be well supported without physio. Unfortunately, they can't be well supported. Nobody can do all these things. Nobody can reason the way we have been reasoning. Not doctor, no matter how sound they are, they can never reason this way. A nurse can never reason this way. It is only physio that can think. That is why the way we think as physio is different from the way doctor think, from the way nurses, from the way they think. It's quite different. We all have different scope. It's only physio that can reason this way, that can make sense of all of this jargon we've written here. Okay. PF, medical wards, rattling chest, standing cracky, rattling chest, chesty, increased O2 requirement. What are you worried from positive pressure side of things? What are you worried about? Hello? What are we worried about? Anyone? Anyone helping us? So the idea is for any patient that have got like a restrictive lung disease, just think about these things. Restricted, like maybe their lung is restricted or anything. It might even be something coming up to my head now. It could be ARDS patient, for instance. ARDS patient, again, you have to be careful with the way you use the positive pressure with them, because you can complicate their issue with your positive pressure. You need to be careful with them as well. So now, if somebody have got maybe restrictive lung disease, do you want to just go to their best and now forcefully their lungs is like this? Now you want to forcefully, expand their lungs. You're gonna give them barotrauma. You're gonna give them barotrauma. That is one of the reasons why we need to be careful with our positive pressure as well. So we want to be careful. It again does not still mean I really need to do it. I can still do it, but I will need clearance. And aside from that, I might need to cap, be conservative with the pressure I'm blasting them on. If that makes sense. But again, I want to explore every other thing first of all before I start thinking about, let me go for positive pressure. If that makes sense. You want to be careful with pulmonary fibrotic patients or restrictive lung disease, all those kind of patients. with less compliance, patients that are lungs are less compliant. Because if you forcefully open their chest up, if you don't, you might give them barotrauma and they might even struggle with compliance. Think about that. So really, really very important. So I'm going to just leave all the rest for us. And so cough, I think I've discussed this. This is like a repeat of one of my slides when I was talking about SCI patients. So cough is really important to us as physio in acute hospital. Cough, 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 cough. Unfortunately, you will get a lot of referrals that will say patient is coughing. The patient is coughing. Yeah, then you keep coughing. Cough, cough is a protective airway mechanism. If something irritates your airway, yeah, naturally you need cough to clear your airway. That's not a good referral. You decline and say no physio. If they've not got any other physio intervention, like any other physio indication, like sputum retention, increased O2 requirement, loss of lung volume, workup bleeding, all those things that yeah, I really have to intervene. That is why I keep saying the way even consultants, great consultants that have worked with a lot of physios for donkey years, they still don't think the way we think. I still don't think the way we. That's why I keep saying we should stop putting blames on. Let's do our job. Okay. All right. So now for cough. Cough has 3 phases. Always remember, you should know this as acute physio. And even people in community, people in neuro, people handling pediatric patients, you should know phases of cough and how that relates with your patient. Inspirations. You need air. Normally, you and I now, we need air to fill into our lungs. Diaphragm should descend. We want that rise, nice deep breathing, thoracic excursion, the glottis to close up when the pressure build up, and we want that explosive blow out of the lungs. 3 phases: inspiration, compression, glottis will close, and then you blow the air out. Expiratory phase. Those are the 3 phases of cough, right? That is very important. Again, why do we have to pay attention to this? The reason being that there are some patients that will struggle with inspirations, not being able to inflate their chest. I think if you want to have a good practical of these things, a good practice of these things, if I ask you guys to take in deep breath, cough, first of all, cough now, without just cough. Now, if you're not taking a deep breath and cough, it's going to be another. When it comes to strength, it's going to be another. The strength will be more than when you just cough without taking a deep breath. So generally, in order to have a good cough, you need that deep breath. Deep breathing, that nice thoracic excursion to fill air into your lungs, to build pressure up, to close the glottis before the blowing out. If that makes sense. So there are some patients that will struggle with inspiration. Some patients might struggle. Remember, I can start giving a lot of instances. Some people might be because maybe spinal cord injury patient not able to ventilate, taking in deep breath. It could be patient with surgical patient, pain, restrictions, everything like that. It could be patient with phrenic nerve injury, like you can have in your SCI patient, something like that. It could have people with compression issues, closing of glottis, like Bobo palsy, all those neuromuscular conditions, all those kind of patients. You can have people weakness with expiratory muscles to generate that strong cough, to contract the external intercostals and the abdominal muscles. You could have in SCI patient, you could have in neuromuscular or neurological condition patient like Jury-Barron syndrome, spinal muscular atrophy, what is it again? Anything muscular, anything neuromuscular disease patient, you have to pay attention to. It could even be in stroke patient. So think about this thing. You need to assess those things. So, and again, when you think about cough augmentations, I think it's just a repeat of some of those things I've touched in the past. I just feel like repeating this because it's really important. When it comes to cough augmentations, you have to, there is peak of flow, device that measure the force of the air you blow out. There's a device, peak of flow. Now, generally, some people have come up, do a lot of researches and come up with a lot of values, figures, or something, numeric values, but sometimes it might not be absolute, like, yeah, but it's just to give us some kind of reasoning. Oh, if this is this, then I might start thinking in this lane. Oh, my brain is start going in this lane. For instance, if somebody has, of course, peak of flow greater than 270, we might not need to be worried. is able to cough and clear their airway by themselves, no, cool. They might not need us. If somebody have maybe peak of flow of between 160 and 270, we might be thinking about cough augmentation for them because they're at risk. Their cough is impaired, their cough might be inefficient. You see the English I'm using might be because it's not absolute. Okay? They might be needing cough augmentation, like, oh yeah, maybe we can ask them to do breath stacking. What is breath stacking? Breath stacking is just you taking in deep breath, you hold it, you put another, what is it? You put another deep breath on top of that, like taking deep breath, hold it, taking another deep breath, then asking your patient to cough. What are you building? You are building pressure in the thorax. You are building pressure in the thorax. You are building, what is it now? Their inspiratory flow to generate their exploratory flow, exploratory bias. If that makes sense, you can do breath stacking with some patients. There is also another thing you can use long volume recruitment bag. It's just this bag is also, if you put it on your phone now on Google, it's going to bring it out for you. This is also for patients that are struggling with deep breathing. You can just to augment people's deep breathing or to replace people's deep breathing. They cannot even take in deep breathing. Then you ask them to cough after that. These are people struggling with it. Then you can mark. These are first you can provide for people's thoracic region or abdominal region. You can thoracic mark patient, you can have to mark patient. If you go back to SCI, these things, I've sent the slide as well. Some of these pictures are there. Go over these things again. Okay. And if somebody have maybe peak of flow of less than 160 because of any reasons, neuromuscular disease, critical, patient with prolonged ITU stay or anything, they've been treated and been very sick, treated with steroid, their muscles have been weak, anything like that, or SCI patient or something like that, and their peak of flow is really, really low, like less than 160, 150, 140, we might be thinking about, yeah, we need cough assist. We need cough assist for this patient group. It could even be maybe patient that have been sedated for a long time, sedated, paralyzed, and been intubated or anything like that. So they might be needing some of these things like cough assist. So with that, so I'm going to just talk about, I will talk about cough assist. But before I do cough assist, I really have, because we just have maybe one more episode for this series. Then the rest might be maybe next year. But I just really like to talk about this assessment before maybe I just talk about cough assist, and maybe we just do the ventilation maybe some other time. So now for assessment, respiratory assessment generally, think about A to E assessment. System, you know, I know we love systemic things. Like this we actually cover those systemic assessment that we really want to do with our patient. Anytime you want to do respiratory, just think about it. Here, A is the airway. What are we looking at in the airway? Now I need participation here because this is what we should be familiar with ideally. I need participation. In the airway, what are we checking for patient airway? Please, just pop response in the chat box, quick, so that we can move away. I just talk about cover assist, and maybe I end the class for today. I'm getting tired now. Yeah, hey, cover assist. Not cover assist. Hey, airway. What are we checking in patient airway? You go to their bedside. What are you checking? Patient airway. What are we checking? You are checking.
Secretion.
Yeah. Let me check.
Secretion.
Yeah.
Secretion.
Yeah, great. You might be checking for secretion. You might go to some people's bedside and you might find that they might have audible secretion, like sounding. What is that? You pay attention to that. What is that sound they are making? Is it gargling sound? Is it looking like steroid? What is stridor related? Is it? Pay attention to those things. They mean something to you as a patient. What do they mean? Peter Ajara have written that in the chat box. They mean patency. Is their airway patent? Is their airway patent? Pay attention to those things. Is it snoring kind of sound? Is it secretion related? Like, something like that. This thing should make sense of you. Even before you plug your step on someone's chest, or even somebody making that sound, I don't really need to even plug my step on their chest. Do you know why? Because if I plug my step on my chest, what am I going to hear? I don't hear. It might be difficult for me to pick what is in their chest. Because the sound they are making in the upper airway, secretion in the upper airway will not allow me to get adequate things in their chest. I don't really even need to plug my step in their chest. What I just need to do is palpation. That palpation is really important. I love it. By the time you palpate, you might even use your palpation to detect, okay, where is the secretion, tactile femoral, blah, 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 those kind of things. Yeah. So because of the noise they are making, upper airway noise, you might not be able to pick that. We should be able to know all these things. Yeah, thank you, PT Ajara. You are looking at their airway patency. If the airway is not patent, this is emergency. This is where we have these A to E kind of things. Escalate immediately. Somebody stridor related kind of things, airway issue or something, or somebody choking, somebody is being choked, it's something. So we need escalation, we need those our airway management techniques, we need everybody put the curve crash button, everybody should come around. We need to, because if we don't do that, what is it? Don't be able to get in oxygen, hypoxemia will kill them quickly. Hypoxemia kill faster. So we need that. Airway emergency, that is why we have this accepted in that order, one before another. So patency, you are looking at their patency. Thank you, Peter Ajara. Thank you for that secretion stuff as well. Okay, what else are you checking? You're also checking, is it their whole airway they've got, or they've got breathing tube? Because you know, as physio, somebody can breathe through breathing tube, plastic in their chest, as in tracheostomy. Somebody can have tube through their upper airway, like a ET tube and the trachea tube. Is it, you document those things in your note? Oh, patient audible, if you hear audible secretion upper airway, blah blah blah. If it is there, we can say hone, patient own airway, patent. Blah, blah, blah. If they've got, you call ET tube, what size? Tracheostomy, what size? And go back to those teachings. They're very important. We can't talk about that here. So now, if the airway is patent, cool, you move forward. But if the airway is not patent, you stop. Stop every other. Every other is not important at the moment. What is important is that they are airway. We need to manage our airway first of all, if that makes sense to somebody. Breathing, what are we checking in breathing? Quick, fast. What are we checking? Breathing. Physio, please. Fast. Let's rush a bit now. What are we checking in their breathing? Max?
Is he calm? Or distressed?
Yeah, great. Yeah, what else? Yeah, we are looking at them. Are they calm? Are they in respiratory distress? What is their work of breathing? What is their respiratory rate? We are looking at those things at their bedside. And now people will talk about this look, listen, and feel kind of things. Look, listen, and feel. Look, what are you looking? You are looking just like what they are respiratory. You can pick. If somebody is visibly fatigued, you can tell. We know. You know the way they will be presenting in bed. Look at those things. Listen. What are you listening? You are listening with your stead. You are this thing. Palpation. Feel for their chest. What is the tactile femoral? All those things. Feel for those things. What else are we picking with breathing? What else? With breathing. What else are we looking at with breathing? I don't just want to do this thing and go. I want our participation here. What else are we picking in the breathing? There are a lot of things. Yeah. What else? Put in the chat box.
Asymmetry of the chest.
Yeah. You're also looking at their chest rise. Sorry?
Asymmetry.
The
chest
depth of
asymmetry,
their
expansion.
Yeah, great. So while you are doing the palpation, while you are palpating their chest, you are doing the two things at the same time. You are feeling for tactile femoral. You are also looking at their thoracic expansion. Is it adequate? Or not? Now, the question is, thank you for that. How do you know if patient thoracic expansion is adequate? Forget about this value. People will put value to it. Adult to be this, that's nonsense. That is pure arrant nonsense. How do you know? How do you deem someone's thoracic excursion to be adequate? I will come back to that question because I will still ask that question because I want to teach cover assist. I'll still ask that question. But let's concentrate on this for now. But just have that question at the back of your mind. Yeah, thank you for that. You are feeling for palpation. You are looking at that. Somebody mentioned depth of their breath. You are paying attention to those things. You are looking at you are looking at their work of breathing. You are looking at those things. Really important stuff. Really important. How are they presenting? What else? Are they ventilating on room here? Are they on oxygen? This is breathing. Are they breathing by themselves, using FiO2 in the air to drive oxygen to their lungs, or are they using oxygen? If they are on oxygen, what amount of oxygen? What device? Are they on Venturi? Are they on nasal spec or nasal cannula? Are they on humidified? Are they on aqua pack? Are they on high flow? Are they on? Some people might even be on positive pressure now. Some people might be on NIV BiPAP. Some people might be on CPAP. To pay attention to those gadgets. Now, if they are on BiPAP, I'll still talk about it, those parameters. What is their EPAP? What is their IPAP? Forget about those ones for now. We'll talk about those ones. But now, if they are on oxygen, you can relate oxygen. What amount of oxygen? What is their SpO2? What is their target SAT? You go in lane of oxygen now. If you are looking at the oxygen, you don't just, yeah, the oxygen, no, you drag the ox machine, check their hops. What is their SpO2? Then from the medical note, I expect that before you come to their bedside, you have checked their target SAT. What is their target SAT? Are they on scale 1? Are they on scale 2? Because you cannot deem somebody desaturated without even know what their target SAT is. That does not make sense. That does not make sense. Your brain, like I used to say, your brain is not programmed. You are not programmed. You are working with, you are treating what you are saying. So I expect that you could have checked the medical notes to pick what their target SAT is. By the time you come to their bedside, you plug that probe or what we call pulse oximeter in their hand. And you now look, oh, they are 86, they are 92, they are based on what their target SAT. You can say, yeah, they are desaturating. If they are desaturating, you need to increase the oxygen. Do you need to bolus the oxygen? Do you need to change the oxygen device? This is what physio do. This is what physio do. Do you need to change the oxygen device? I don't need doctor to prompt me to do that. Because even though oxygen is a drug, they need prescription. But in emergency situation, you can change, you can escalate, we have discussed oxygen. Go back to those things and learn those things. These are skills everybody must have to work effectively in acute hospitals. Check the oxygen. What other thing are you checking? Yeah, there's still a lot of things we've not done. There's still a lot of things we've not done. Sorry?
Whether the abdomen moves with respiration.
Yeah. You are checking everything, respiration, everything breathing. You are looking at the abdomen. Are they coughing spontaneously? That abdomen, yeah, I want to pay attention to the abdomen. That I'm also linking it to cough. And their bedside, I'm also paying attention to them. Are they coughing? Some people just go to their bed, they are coughing. You pay attention to that cough. You are looking at the strength of the cough. You are looking at, are they coughing and clearing, the effectiveness of that cough? Because that is really important to you. You are looking at the effectiveness of that cough. Not that alone. You are looking at that cough. Is it wet sounding? Are they sounding wet? Like, oh, if somebody has secretion, you will know with their cough. Are they sounding wet or is it dry? If they are just at the bed and they are not even coughing at all, what do you want to say to them? You want to question them and say, Mama, give me a big cough. Show them how to cough. Show them how to do those things. Mama, do you want to? That cough is really important. Cough, you don't joke with cough as physio, as respiratory physio. You don't joke with cough. Assess their cough. Okay, what other thing are you checking? Yeah, you don't, before you again.
For the rate.
For
the rate, count how many times the chest. For the rate of the rate, count how many times the chest rises in a full minute.
Yeah, absolutely. You can look at their chest rising and falling. You can look at that. You can look at, yeah, is it faster than normal? Is it normal? Is it normal rising and falling? Are they in any distress at the moment? You look at that. Really important. What other thing are you checking?
Does it use the diaphragm to breathe?
Yeah. Perfect. Some people might be doing paradoxical breathing. You are paying attention. If it is paradoxical breathing, as you'll be able to pick up that and say, yeah, no, escalation straight. Because if that is not escalated, some people might need to go on another ceiling of care. Some people, medical intervention needs to take place. You're looking at, aside from that, what other thing are you checking? Before you come to their best, I expect that you have checked their chest X-ray. I expect that some people, sorry?
Irregular breathing.
Yeah, irregular breathing. Checking
I changed throat.
Yeah. Check their chest X-ray. Check their ABG.
And also listen to the sound.
Yeah, listen to their chest as well. Listen to them.
Whether you are having a wheezing sound, gumbling noise, and so on. Noisy airways.
Thank you. When you listen to their chest, you are listening to their breath sound. Is the breath sound equal throughout? Is there good air entrance, or is it silent in one part of the lungs? Are they standing cracky? Are they standing? And if they're standing cracky, is it doing expirations? Is it doing inspirations? Is it whistling sound? You can even have a mix of cracking sound, background of whistling. Somebody it might not necessarily have to be asthmatic before you start whistling. Well, because of a mucus plugging in their lungs. Listen to their chest. So in summary for this one, you go to their bedside, breathing now, everything breathing now. You look at, oh yeah, are they on oxygen? What devices? Do I need changing the oxygen? Blah, blah, blah. Or are they on NIV device? Or if it is intubated patients now, like ventilated now, you look at their very parameters, the PEEP, the positive, forget about this, the pressure support, forget about those things for now, forget that. Don't let me go in that lane. So now, aside from that, you listen, you palpate their chest, look your chest excursion, thoracic rise, palpation for tactile femmetors, you auscultate them. Some people do percussions. Yeah, some people do what do you call it? Percussion, but it might not necessarily do that. Yeah, it's all about, and again, you do not really have to do everything. Sometimes I might not even need to plug my stent to somebody's chest before I know what is going on. I have read that, I have looked at their chest history, great. I am at their bedside. I have listened to their strength of their cough. That might be enough for me, depending on your clinical reasons, depending on how experience you have. Sometimes why am I just, if I'm with PIT, I love palpitations when it comes to PIT, because of their noisy upper airway. And sometimes I just need to tilt some of their head, just tilt their head up. Then if I need to auscultate, then I will then auscultate. Because sometimes if you don't tilt their head up, you might struggle to pick anything in their chest because of their noisy upper airway. These are just clinical reasoning kind of things. You need like work with people that are really, really very experienced, interact with people before you know something. It's not textbook reading. It's not, this thing should come with like people that are doing it. Let them come and teach us this thing so that we can know. No textbook. Textbook might not tell you something. So I go because of time. C. What is in C? Cardiac. Circulation, anything circulation. What are we checking? Circulation. Quick. What are we checking? Circulation. What are you checking at their bedside? Fast. What are we checking? Yeah. Sorry. What are we checking? Circulation. Everything circulation. You are looking.
Capillary refill time.
Yeah, great. You are looking at capillary refill time. You are looking at cyanosis, central cyanosis, peripheral cyanosis. Great.
Hypothermia.
Yeah, you are looking at temperature, everything. Yeah, you can drag up machine, check these things yourself. You can look at temperature before you come to their bedside. Look at the trend. Look at their blood pressure. Everything comes in place here. Their blood pressure, their heart rate. You pay attention to those things. Yeah, this is what you are checking. Check their blood pressure. Check their heart rate. Again, you know your procedure, whatever things you want to do, you also have impact on their blood pressure and their heart rate. And aside from that, before you come to their bedside, some people bring in blood, like lab. I expect that you could have checked their HB, check their platelet, check their INR. Because I know, why am I checking platelet? Go back, we have said this in multiple times. People can bleed. If their platelet is like spontaneous bleeding, the INR, you need it. If you need to do positive pressure, what is the INR? Have you checked? What is their platelet? Have you checked? I want to do positive pressure. Have you checked their INR? Have you checked their platelet? You can't just go and start jumping on someone's chest and start abdomark them or giving them positive pressure. You have to check all of these things. Again, infection marker. They are being treated for chest infection. Have you looked at the trend of the CRP? Have you looked at the trend of white blood cell? And subsequently, when you are doing your treatment, they are on antibiotics and everything, the medical team are doing, and what you are doing, are you checking all of these things again? This is how you are working together, and you are tracking the progress of your patient so that you know when to stop and when not to stop. Okay? The D is everything. What is it? D is everything disability now, everything neuro. I'm looking at anything neuro, alertness. If I can do GCS, depending on where they are, maybe ITE or something, I can do RASCO. Go and learn RASCO. We might not be able to touch this thing, some of these things. Go and learn RASCO. Very important. GCS, score GCS appropriately. I mentioned in when I was teaching, we've done it in the past. People should be able to score it like accurately. Again, aside from that, if it is word-based, I might just do a CVPU. Like, are they alert? Are they confused? Are they verbally responsive? Are they responding to? I might just do that and go away. Anything neuro, glucose level, I might be checking that. E is everything else that I have not checked. Everything else that I have not checked. And what attachment have they got? What is infusion have they got? Some people might have blood pressure medication infusion running through. You have to check. Some people might be on potassium infusions. Some people might be on what is it? Some people might be on, they might be on potassium replacement or sodium or anything. Some people might have urine catheter. You want to look at their urine, what color is it? Just pick some other things that you feel like you need. So I'll put some of these things into writing for us so that by the time we are checking, we know why we are doing these things, and it's going to cover everything. And again, so just look at what is really, really important. I don't really have to run everything, but it just depends on my clinical reasoning. Why am I doing it? And why am I checking some certain things? So I put it into writings. I will just spend little time on cough assist. And I'm going to stop. We might not be able to take other positive pressure, but I feel like this conference is really important to us. I'm going to just touch on this. Let me take some first. So any questions, guys? Any questions so far? Any questions? Is it making sense? Are you getting any value from all of these things? Please, can I get a response before we start? Who I'm using that to relax? Yeah, Peter Ruben was talking about pulse cyanosis. Yeah, Momo, I might not really very keen on getting patient at Momo, honestly, because where I really want to just treat is just their respiratory disease, honestly. I might not really very keen on the cardiac part of it. Just do the respiratory, just auscultation using their bedside, listen if they are cracky or these things. Cracky might be, yeah, they have evidence of secretions. Okay, they are silent in one lobe part of the lung, maybe right side or left side or basal part of the lung. Might mean that, oh yeah, maybe they've got atelectasis, maybe they've completely got consolidations on that part of the lungs or something. Just picking that. And again, when I'm palpating, I cannot feel anything in one part. It might be that maybe there's little hair entering in that part or something. So it's just clinical reasoning. There is no direct way to all of these things. It's just clinical reasoning. Yeah, how do we determine the target vital signs? Yeah, so target vital signs generally are not set by physios. They will be set by medical team. There are certain criteria. I have explained some of them in the past. And again, it's something that some advanced, like really, really very well-trained physios can also do in some hospitals based on clinical governance and based on level of expertise as well, but there's nothing really there actually. For instance, now, like the targets that you really have to be familiar with is in terms of SpO2, for instance, and level of oxygen in their blood. So generally you can have scale 1, scale 2. Scale 1 can be maybe anything greater than 95, 96, something like that. Scale 2 is just 88 to 92. Maybe people that have chronic conditions like chronic COPD, that normally CO2 is normally in their blood for a long period of time. So they struggle to ventilate well, something like that. I might not talk about full physiology because of time. So people like that, like some neuromuscular condition patient like what is it, Guillain-Barré syndrome, motor neuron disease, or people with kyphoscoliosis patients, something like any chronic conditions, they will normally set them to be maybe 88 to 92. So if I go to their bedside and their oxygen level says, let's say 92, I'm fine with them. 92, I'm fine. I'm not worried, because that would be their target size. But if you are working in like ITU settings, you're going to find a lot of target ups that will be set. You can find CO2. They might set CO2 to be target CO2 to be 4.5 to something. You might find maybe FiO2 to be this. Maybe even on ABG they might say yeah, on ABG we want the PO2 to be targeted around this range. Just look at the medical note and work along those things. And speak. And sometimes you might be concerned about some target as well. Speak with the medical team, relate your clinical reasonings. You speak together. We are not enemies. We are working together. No one knows everything. So that's how it is. Cover assist. Hope I've answered that questions. But at what base level, just read. If they've not documented in the medical note and you don't know and you are going to that person, ask them, oh, what target SAT are we aiming at? But generally, usually, again, even myself, if patients are not, or it's not something you want to always assume anyways. But generally, if you look at medical, there's nothing like chronic lung conditions or anything. I might just say, this patient is going to be on scale 1, but don't always assume. Anyway, let's continue. Yeah, cover assist. So mechanical insufflation, exsufflation. So first thing I'm going to tell you guys here is there are different brands, there are different makers, there are different distinct to it. This is just practical based, but we can build some basic clinical risk. Hopefully, maybe at some point we might come down and maybe we can have some of these things, show ourselves how it works, clinical reasonings, more practical related kind of things. But for now, there are different brands, there are different models to do things. But what really matters is just the parameters and why we can be changing some of these parameters, like in terms of to suit the need for our patients. So, but first of all, know there are different makers. If you go online, you're going to see different types. Well, okay. So it's just, what matters is just the clinical reasoning part of it anyways. So, of course, this is just the, for this one, this clear, we won anyway. But so again, if I really have to do cover assist for somebody, again, some patient might be on oxygen already. Maybe 40%, 50%, 60%, blah, blah, blah already. They are poorly. And I've cleared my contraindication part of it. And this is what I want to use at the moment. I have to think about these things. If I want to do this, I'm going to disconnect people from oxygen to put this mask, just like you've seen in the picture. Some people interface can be mask, it can be mouthpiece, for instance. And if they are intubated, maybe they've got trachea or they've got endotracheal tube or something, then I might need to find interface that will fix into their breathing tube, if that makes sense. But if I'm disconnecting somebody from oxygen, I need to think about, do I need to plug oxygen to this cover assist machine? I need to think about that. And how do you reason that? It could be that, oh, maybe this patient are just desaturating anyhow, any small change in their, maybe oxygen, if they're having oxygen through their nose, through nasal spec, or through the mask of oxygen they are using, any little change, they are desaturated. And I think about, oh, let me plug oxygen to the circuit or to the socket of cough assist. And I think about that. If you look at what I'm touching on the screen now, this is like oxygen entrainer now. So oxygen is being entrained to this socket. Yeah. So I can plug this oxygen tube can come into here, and I can plug it to the wall or cylinder, oxygen cylinder, and I'm fine with that. Think about that before you start using. And at the bedside now, I have to think about that first of all. I have to figure that out. Do they need oxygen or not? Generally speaking, I would say if somebody have got maybe 40%, 60% oxygen, you might want to say, oh, I'm going to entrain oxygen to my cough assist so that they will not desaturate. Because cough assist, let me say this, cough assist work with, what cough assist does is you puff here into someone's lungs, and it's going to create, that is positive pressure. Cough assist is just two pressure now, positive pressure and negative pressure. Positive pressure is the here you are puffing to the patient's lungs, and the negative pressure part of it is like the cough that will be generated, the air that will come out. That's the negative pressure of the part of it, if that makes sense. So that negative pressure is going to be like a kind of hoover that will bring everything here, everything secretion up into patient's upper airway so that you can hear. If they can cough, you can cough it out. You can cough it out. If they cannot cough it out, we can do suction or anything to clear it out from them. If that makes sense from somebody. So in the course of doing that hoover, that negative pressure, bringing everything out, the chance is there that patient can desaturate. We call it lung de-recruitment. Some patient can de-recruit. That is the jargon we use. Some patient can de-recruit. In that regard, I have to think about, do they need oxygen? If they need oxygen, I will entrain oxygen. Done. If that makes sense. Now think about interface. Do they need? Go back to that contraindication. Somebody can have fracture in their face. Somebody can have bones. Some people can be what is the name? Claustrophobic. They might be if you put mouth, they will just shaking until hard, like they want to die. They don't like being choked or something. Think about that. If that is your patient, think about what interface do they need. And if it's trachea, if it's laryngotomy, think about if somebody have got breathing tube in their neck, what interface? I cannot put face mask. I need something that will connect this machine to their neck. If they have breathing tube in their mouth, I need something to connect that. I need to disconnect them from ventilator and connect them to this cough machine. Think about interface they will need. It's just clinical reasoning we are building, right? And again, overall, how do you measure effectiveness of this cough assist? You are looking at patient comfort. In patient that has, now what patient group can I use this cough assist machine? I can use it for self-ventilating patient, just like you and I. Self-ventilating means I am not using breathing tube. You are not using plastic in your neck or anything. We are breathing normally, our own upper airway. We are using that. Okay? You can also use this for intubated patients, patients that are being sedated, ventilated, or this thing. You can use it for them. Okay? So you are weighing your comfort. You are balancing comfort and effectiveness of this machine. You are putting the two side by side, especially for self-ventilating patients. You don't want, because there are some settings, if you put in machine on some settings, it might be very uncomfortable for them. So we are looking at, how am I going to balance this comfort with effectiveness? Think about that. It's really important. And patient pathology, what pathology have they got? Is their problem breathing issue? Like breathing in is their problem. If the breathing in is their problem, when it comes to like tracking my tracking my settings, I have to be thinking about the settings that I will put here in I'll puff here in. I need to be taking it. I need to think about that. If that makes sense. If the problem is cough, expirations, I also need to think about, oh yeah, I need to start thinking about, oh, what pressure will support expirations, if that makes sense. It's patient specific. It's patient specific, very, very patient specific. It's case by case based. If that makes sense. All right, so these are just some of these. Like I mentioned, you can use it for self-ventilating, tracking patients, blah, blah, blah. So now these are just some of these interfaces you can find. Like this one now, this one can go to ventilator, patient on ETT, patient on tracking their neck. This interface can fit in. This one can fit in. This is mask here, you can see. So if I need to disconnect this thing here, from this is patient on ventilator, I'll just disconnect this thing from here and I plug my cover system here. This is just like that kind of things, just to familiarize ourselves with it. Perfect. Okay, let's talk about mode. Okay, mode is another thing, really important. So yeah, generally just orientation, basic clinical reasons. There can be manual mode, like you clinician you're going to control the numbers of breaths you give to patients, the numbers of breaths you are just controlling everything. The numbers of breaths you want them to get before they cough, you are the one controlling that. And again, there are auto that you just put the settings on the machine and the machine will run the business for you. So I'll just talk about those two here. So now, before I talk about these things, I really want us to look at these things to make it very, very simple and relatable. Think about ACBT kind of things. Are we still there, please? Hello? Are we still there?
Yes, sir.
Hello?
Yes, sir.
Yes, we are here.
All right, thank you.
We are there.
All right, thank you. So thank you very much, everyone. Thanks. So think about ACBT kind of things. You know, ACBT, there is a part of I don't know what you call it now, of ACBT that talks about thoracic excursion. You know, ACBT has breathing control, tidal breathing, you just do relaxed breathing, then like and there is a part that you ask your patient to feel in here to their thorax, to bring their thorax up, like taking in deep breath in. You want that nice thoracic excursion. That thoracic excursion is what I need in that ACBT. Now think about that. If I need to cough assist somebody now, if I need to cough assist somebody, remember that thoracic excursion. If I need to puff in here, remember that thoracic excursion. Now, why I'm puffing in here is I want that nice thoracic excursion to take place, if that makes sense. Now, so what pressure is going to help me to do that? It's going to be positive pressure. Don't forget, positive pressure is the pressure I'm giving to support their inspirations. As we call it insufflation pressure, like you can see here, insufflation pressure. And the one that will do the Hoover effect, that will do the clearance effect, is that exsufflations, negative pressure, insufflations. If that makes sense, you can see them here. You can see insufflations, insufflation pressure, you can see exsufflation pressure, if that makes sense to somebody. So now, before I talk about mode kind of things, now let's just first of all do basic reasoning here. Basic reasoning. Generally speaking, what literature have recommended is, if I need to give puff air into a patient's lungs, adults now, let's say adults now, for instance, what they've recommended is, start with pressure of maybe 15 to 20, then build it up from there. And again, you don't just want to go to patient better and just blast topmost pressure. No, it does not make sense. Don't forget, if you overdo heat, if you overgive them pressure, you can leak here into their pleural cavity. You can create pneumothorax. You can give them barotrauma. You don't want to hurt your patient. So start from low pressure and start building it up from there, if that makes sense. So now, I may want to do my starting pressure, maybe 20 or maybe 15 as for adults. Now, what will I be watching that will tell me that, this positive pressure, that insufflation pressure, the breathing in pressure is okay for this patient? What will I be watching? I need to look at their chest, thoracic excursion. I need to look at their chest to tell me that, yeah, this is enough. Now, I asked a question the other time, and the question is, if you are asking a patient, we all do ACBT, we all know what ACBT means. How do you know, you are telling your patient to do deep breath? How do you know that deep breath is good, like that is enough, like that is the adequate for that particular patient? How do you know? I don't know if you guys understand. If you, let's say you are the physio now, I'm your patient, and you're asking me to do ACBT now, and we get to that thoracic excursion part of it, and I do deep breathing, hold 3 seconds, 1, 2, blah, 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 3 seconds. How will you know if that my thoracic excursion is enough, is adequate? Or we don't do, or do we pay attention to that? How do we know if that is adequate for that patient? How do we know? Because that knowledge will be needed here to give your patient adequate insufflation pressure. You need that knowledge here. How do we know that that thoracic excursion is adequate? How do we know? Don't forget what they recommended for self-ventilating patients. Start from 15, 25, 15, 20. That's what evidence is. If patient is already on positive pressure, another one, let's say on NIV, or maybe they are on mechanical ventilator, I might just look at their peak pressure or pressure support and just add maybe 5 to that. For instance, if they are previously on maybe pressure on ventilator now, maybe they are on 20, I might just add 5 to that and say that let me start them from 25. Because they're already having pressure on ventilator, and that is giving them adequate tidal volume. Then I will just add 5 on top of that, and that might be enough to give them thoracic excursion. But some ventilating patients, they are not on breathing tube, they are not on anything. You go to their bedside. How will you know the appropriate thoracic excursion? The question might be tricky. Let me answer the question because of time. The answer to that is this. Now, what I do is just like clinical reasoning kind of things. By the time I get to my patient bedside, just like when we are doing our assessment, pay attention to their normal breathing, the way their thoracic is rising and falling. So if I need to track if I need to track this reading here, I would just say, oh, in my head, I might be like, based on other assessment, like, or maybe this sputum load that I foresee that might be in their chest, I might just be in my head. Maybe I just need maybe 25 more thoracic rise for me to be able to clear their chest, or maybe 35% more of that chest rise. Because listen, why you want that? The idea is this: I really want that good normal breathing. Now, you and I, we are doing normal breathing, tidal breathing. The chest is just rising a bit and falling, rising a bit and falling. It's just like if I want patient to do thoracic excursion of ACBT, I want good rise, good chest rise. Why do I want good chest rise? It's because I know when they do that good big, when they take in long, big, deep breath, when they do that, what happens is the air go far down into their airway. There is something we call collateral circulations. Through the channels, if you put it on Google, there are a lot of channels of Lambert, blah, blah, blah. Put it on, you find their names there. There are a lot of channels in the lungs. So the air will go through their channels and go behind the secretions. That is why I need that nice deep breath. And that is why I need that thoracic excursion. So the same concept here. If I want to give somebody positive pressure, I want to go far beyond, like I want to hyperinflate their lungs a bit beyond their normal tidal volume. Let me repeat myself. We are doing deep breathing in and out now. If I want you to do ACBT now, I want to do that thoracic excursion in ACBT. I want that your thorax, that chest excursion to be more than what you are doing at the moment. That is what I'm saying. And the reason for that is because I want here to circulate around, nicely around in your lungs to move secretion up a bit. Collateral ventilation, if that makes sense. The same thing here. So what I will be looking at is I will look at their chest rise at their bedside. Then I will do I can start like 25 or 20. I will look at it. Oh, if I'm not happy, like I need more rise than this, I might maybe had 5. Of course, the recommendation is going 5. Like I can just do 5 more to see how more thoracic excursion can be for them. If that makes sense. Because I know for me to mobilize secretion, for me to have good cough, I want inspiration to be very, very good. If that makes sense to somebody. Think about that. Now, then again, generally, if it is manual mode, what you just need to set in manual mode is just insufflation and exsufflation. Now, the idea for exsufflation is, what recommendation is I've put it here for guys if you really want to read all of these things I'm explaining. Now, for exsufflation, now the recommendation is don't forget what I explained initially. If you puff in here into someone's lungs, we need to bring out the air, We need to bring out the secretions in the lung and every other thing in the lungs. So the idea is we want good expiratory bias. There's something we call expiratory flow bias. Between the, like, if I need to sort my insufflation now, I want the pressure of insufflation to be more powerful than insufflation. That's what I'm trying to explain, make it simple. I want it to be more powerful, like more negative. Negative pressure, insufflation is negative pressure. I want it to be more negative. So I will just do it like, if I'm doing positive pressure, insufflation 25, I can do that one like maybe minus 30. I can do it minus 35. So people like to go between 5 to 10, 5 to 10, 5 to 10, 5 to 10, or start with 5. Start with 5. So like I was saying, if it is manual mode, I'll just set my insufflation, look at their chest rise. Chest rise, thoracic excursion is like your outcome measures you are using for insufflation, if that makes sense. Now, if I'm starting with 15, for instance, insufflation now, I will just do my insufflation like, I'll just do it maybe minus 20, for instance. And I will be the one. The other thing you might find in some settings of cough assist is might find that something we call T-rise. This is the issue now. There's something we call T-rise. T-rise, what T-rise means is, we call it ramp. Some people call it ramp time. Just picture a fan. Because these things, if you don't understand some of this jargon, again, to even up like working parameters of ventilator, it might be difficult as well. I don't know. I'm just doing my bit to explain anyway. So now, T ramp is just how quick can your what is it now? T ramp only affects your insufflation pressure. And what that T ramp talks about is just, or T rise or ramp talk about is just how quickly can your ventilator or your cough assist reach that top pressure. Let me make it clear now. Let me give an analogy. If you have a fan, for instance, if I plug a fan and I on a fan, you know, the topmost speed of that fan is going to build up gradually. It's going to start like this, and let I do like that. That is T-ram. Now, T-ram is how quick does that pressure, does that speed of that fan quickly build up. That is what T-ram is talking. Now, think about it. Now, if you set the time very small, T-rise very small, it's going to build up quickly, like that. But if you set a long T-rise, a long ramp time, it's going to take a long time before it builds up. There is implication for that when you are treating a patient. For good effectiveness, like if I really want to quickly deliver my insufflation pressure in manual mode, if I set the T-rise to be very small, it will deliver. But think about patient comfort. Patient might not like it. It might be very discomfort for them. But for patient comfort, I might need to lengthen my T-rise. I might need to lengthen my T-rise, my ramp time. You might find that on some modes of cough assist. Again, another thing is this. If I'm lengthening my T-rise, my ramp time, lengthening my ramp time means that if the speed that the fan is going to use to build up pressure is going to take a long time, which means that before, now don't forget there are two cycles in cough assist, positive cycling and negative cycling. Positive cycling and negative cycling. If you are not be careful, your positive pressure might not complete before you start your negative pressure. I don't know if this thing is making sense. I'm just trying to explain in a way it's going to make sense. But let me come back to these things. I don't want to complicate it. These are practical related things, honestly, unfortunately. But let me repeat again. Cough assist has positive cycling. I give you air, I blast air into your lungs. That's positive. Hoover event, I remove the air, I remove the secretion out of your lungs. That's negative pressure. If I need to set, I put positive pressure, insufflations. What do I check? Thoracic excursion, chest rise, to decide if it is optimal, if that makes sense. Now, insufflations, for that Hoover effect to be effective, I want it to be slightly positive. I can make more negative, maybe -5 on top of that, or -10, or start low and build it up if need be. If that makes sense. Now, how do I know if I need to increase my insufflation? Don't forget, insufflation is like clearance. Now, if I'm not clearing well, I might need to increase my insufflation pressure. If that makes sense. If the strength of the cough I'm getting is weak, I might need to increase my insufflation. And again, some patients, if they are self-ventilating, they can communicate verbally, they are fine, they have good communication. They can even tell you that, oh yeah, that esophageal is okay. They might tell you that, I think this cough is okay. Some patient might verbally tell you that, if that makes sense. But I now introduce another concept in manual mode. And I introduce another concept in manual mode, which is T-rise, ramp time. So what ramp time? That just imagine your fan. It's just the time it takes to build up the greatest pressure. If that makes sense. So if you shorten it, it's gonna reach that greatest pressure, that set pressure, that plateau pressure that you've set for insufflation. For instance, and the insufflation on the screen now is 25. It has set my ramp time to be 2. And I set another, that is cough. I have 2 cough assists now. The first one, I set my ramp time to be 2. The second one, I set my ramp time to be 0. The one that will quickly reach that 25 first is going to be the 2. The first cough assist that I'm setting on 2. If that makes sense. But like I mentioned, for effectiveness, 2 might be effective. 7 might not be very, very effective, but it's going to be very, very comfortable for patients. But again, I still also need again, because I need it too. I need to balance the two, especially if you are working with self-ventilating patients. I need to balance the two. Comfort plus good effectiveness, good clearance, good thoracic rise. So in that regard, I might just need to go on maybe just find a way to balance your ramp time and maybe increase your insufflation pressure, if that makes sense. But let me just explain some other things. T-rise here, what does T-rise talk about? T-high. T-high is just for insufflation pressure now. You also need to set for other mode now, other automatic mode now. You also need to set your T-high. T-high is just insufflation time. The time you want the pressure, the insufflation pressure to deliver, the time you want them, like how long do you want them to deliver their pressure? The time it's going to take to deliver their pressure. For adult, our normal breathing is 0.8 to, I think our normal insufflation, like normal inspiration time takes around 0.8 to, I think 0.2, something, I don't know, 0.8 to maybe around 1.2, something like that. If I'm giving somebody positive pressure, I'm going to go a bit higher than that. I might go maybe 1.2, 1.3, maybe 2 sometimes as well, depending. I might go 2 so that I can fully deliver that insufflation pressure. I might need to go slightly above the normal, if that makes sense. And again, for effectiveness, again as well, the higher you go on your insufflation time, the chance that by the time the pressure go into their lungs, collateral circulation, lung equipment can easily take place. If I do a short time, it will just deliver positive pressure, and that's it, and come down into insufflation. If that makes sense to some, I'm just trying to explain this thing and build some concept. Unfortunately, it's difficult. Honestly, it's difficult, but that is it. So, but for good clearance, settings you need to be aware of is insufflation pressure, insufflation time for good lung equipment. Insufflation pressure is also very good for clearance. You need to be thinking about how strong it is. The outcome here for that is how strong is the cough. Is it really very strong? What is my patient feeding back to me verbally? And also, are we getting good clearance? But when it comes to insufflation time, there are a lot of evidences that shows that this insufflation time is not really, really very important. But why you find people lengthening that again in acute hospital might be because like 3, 4, 5, 3.5, 4.1, something like that. Might be because that can also be timed again. If you need to do suctioning, like closed chest suctioning, so if patient cannot synchronize well with the cough assist, or patient you are just giving some windows to check if they can cough. Because again, cough assist generally can be used for patients that cannot cough, or they go with weak cough, something like that. So if patients have got weak cough, that means they still have a cough, but it's just that their cough is weak. If you also queen them, you are coaching them well while using the equipment, and you ask them to cough on their insufflations when they need to cough, it's going to give like exponential effect when they are coughing on top of the cough assist that they've got. If that makes sense, but I don't know. This is really practical based. This is really, really very practical based, honestly. But maybe I just stop. Yeah, I just stop. I don't know. But again, maybe the other thing you might need to remember is how many cycles do I need to go? Do I need to do 3 breaths before 1 cough? Yeah. Again, that is another thing to think about from clinical aspect point of view, from clinical reasoning point of view. Now, if you have a patient, they've got secretion retention, they got lung collapse, I might need to think about recruiting their lungs before I do the cough, because the more recruitment I have, the stronger the chance that I'm able to clear their airway better. Think about all of these things. So maybe I just stop here. For it's really difficult to do these things because it's really, really very practical and some based kind of things. So I will send this slide over. If you guys can read through. I've tried to make it explanatory as I can. The other thing I would just like to talk before I end the meeting is cough assist can also be used with other techniques that you've got. You can use it abdomen mark, thoracic mark. You can time it with your function. If you are on closed chest functions like intubated patient, you can use it with it. You can use it with expiratory valve, percussions, chest therapies, ring spring, any other techniques that you've got anyway. But that is it. I'm going to stop here today. Let me get questions. Guys, questions. Any questions? What is the take home from this, from what we've discussed today? Just maybe reflections. What have you, is there anything you've learned today that you think might improve your practice? Anything? Are we still here? Hello?
Yes, we are here. We are here.
We're here.
All right, thank you. Yeah, is there anything we feel like we've gained today? But the reality is we need these things in Nigeria. We really, really need this thing in Nigeria, honestly. And everyone needs to be oriented to these things, to be able to use these things, like good trainings on all these things. So anyone happy to share what they've learned today with us, or what they think today can help them to improve in their practice, or what they will be doing better next if they see another patient? If there is none, I think we just end today. Unfortunately, I might not be able to go further, but these are really practical related kind of things. All right, thank you very much, guys. Thank you for joining. We'll see you again next time. Thank you.
Thank you so much, sir.